Mic test check 1 2 testing.
in our family time to this CME.
I welcome you all to the CME on emerging trends in hemophilia, organized by Hemophilia Society Nagpur chapter and Academy of Pediatrics Nagpur. Also, I am in Nagpur. Excuse me. So today we have amongst us a galaxy of dignitaries. Dr. Ayushi Deshmukh, who is supposed to be here, but she's been held because of some unavoidable circumstances. She's president of Hemophilia Society, Nagpur chapter. Dr. Vithalrao Dange, sir, vice president, Hemophilia Society, and also professor in pediatrics. We have amongst us, we are lucky to have Dr. Shashikant Apte, hematologist from Sahyadri Hospital, Pune, who has done pioneer work in hemophilia. And he is the faculty for today's CME. We also have Dr. Rajesh Phatare, lab head at Sahyadri Hospitals, Pune. He also heads the coagulation lab there. So welcome to you, sir. We are going to I'd like that executive board member of Maharashtra IP.
is behind this hemophilia is Dr. Anju and all who have come here to grace this occasion. I think we all know that there are some diseases which are very important. And we know that in these particular problems, the sufferings are quite high, even higher than the other issues that we come across. But some or other way are not being given proper attention. Not talking about our fraternity, I'm talking about especially the government and all, And because I am dealing with such type of issues like thalassemia and sickle cell disease, likewise, this hemophilia needs an attention. And we have been seeing since last few years that Dr. Anju has done a tremendous job in this regard. And especially when the factors and all the medicines were not available in our city, it was a havoc we could have seen at that time. Patients used to run from here to there, and now because of her efforts and efforts of this society, now I think Dange sir, um, uh, you have got ample of experience, and a person like you, when is associated with such organization, is definitely, we hope that it will give more benefit to the organization and the patients also. Of course, the learning in the whole day about this hemophilia, everyone, we will get a good chance to know about this disease and the new things which have come across. I thank the organizers once again. Thank you so much. Thanks.
Thank you, Dr. Rugani, sir. Now I request Dr. Anju to kindly propose vote of thanks.
Good morning, all. I'd like to extend a big thank you to everyone who has been with me in organizing this event. My association, Academy of Pediatrics, our parent body, Indian Medical Association, my Hemophilia Society, Nagpur chapter, Lata Mangeshkar Hospital, our president, Ayushi Deshmukh madam, and all the people who are here present here on Sunday. Special thanks to all the delegates. And special thanks to Dr. Apte sir, who has come all the way from Pune, and Dr. Fatade sir. They have spared their Sunday for us. Thank you so much, sir. I'd like to thank Dr. Dange sir for being there and promoting and helping us out in taking this thing forward. Thank you, all the dignitaries on the dais, Dr. Jagirdar, Dr. Pankaj Agarwal. He has helped me out with the arrangements. Thank you very much. And I would like to recognize their audiovisual team. Yash Audiovisual, and also Shubham, and of course the Novo Nordisk, who's backed up with the financial support to this program. Most importantly, I'd like to declare that we have a live YouTube streaming going on of this program. And anyone, if you wish to share the link, Yash will be happy to provide, and we've already shared that link on the groups. So thank you so much, and thank you once again. And I thank everybody whom I missed out. Thank you.
Thank you, Dr. Anju.
And I would like to ask Dr. Apte sir to felicitate our MOC, Dr. Mohini Apte.
Thank you all. With this, we move on to the CME. And the first speaker is Dr. Anju Mehrotra. Audiovisual support, please.
Yes, ma'am.
And I invite chairpersons for this session, Dr. Meena Deshmukh and Dr. Pritesh Hatwar. Dr. Meena Deshmukh is Medical Superintendent, ESIS Hospital, Nagpur. She is also Executive Member, Nagpur IIP, and Life Member of Central IIP. And Dr. Pritesh Khatwar, sorry. Dr. Pritesh Khatwar, who is the Secretary of IIP Nagpur chapter.
नहीं मैडम चालू है इधर मैं चालू 2 मिनट
कैमरा मुझे नहीं Good morning, all, and off-station daily faculties. Welcome to Orange City. It's a privilege to chair a session conducted by dear friend Dr. Anju Malhotra Kadu. She is MBBS DCH from Government Medical College. She has done fellowship in intensive neonatal care as well as International Hemophilia Training Fellowship Program. Then she was clinical assistant at UK for some time. Presently, she is in charge of the Department of Pediatrics, Lata Mangeshkar Hospital, and consultant Department of Pediatrics, Orange City Hospital also. She also does her private practice. She is honorary secretary and in charge of Hemophilia Center, Lata Mangeshkar Hospital, Sitabardi, Nagpur. Then she has research and publications to her credit. Then she had some paper presentations also. I call upon Anju Malhotra Kadu, very dear friend, to deliver her talk on EHL factors.
Persons for this kind introduction. Without much delay, we are already short of 10 minutes, so I'll be just going through this topic. Extended half-life factors. For the benefit of everybody here, I would like to just mention first, it's my financial disclosure that I have been sponsored by Novo Nordisk for this talk. And as we are all aware that hemophilia is a blood disorder where it's a genetic condition where the blood doesn't clot. And the body is lacking factor 8 and factor 9, what we refer to as factor hemophilia A and hemophilia B. So what we are aware that the hemophilia A being more common and it forms around 1 in 10,000 of population, and hemophilia being less common and we get only 1 patient in 30,000, whereas hemophilia C being extremely rare. So we are all aware that we have a severity of disease and depends on the level of concentration. The less than 1% is severe, 1 to 5% is moderate, and 5 to 40% is severe. It's mild. So this is a various clinical presentation. Being clinician, I'm sure everybody is aware of. So they have prolonged bleeding from various sites. They get bleeding in joints, what we call as hemarthrosis. They have muscle hematomas. They have easy bruisability, and they have a bleeding, prolonged bleeding after any surgery. And they have bleeding. Mostly the children come to us with bleeding from tooth falling. When the tooth falls and the children are coming and the bleeding doesn't stop. And we have GI bleeding. There are life-threatening bleeds that we all should be aware of, that they need special care and they need intensive care. GI bleeds as well as intracranial bleeds. So as we are all aware that we've seen the evolution of diabetes, and here it is, the hemophilia also has evolved over the time. So we had earlier used to treat hemophilia with just whole blood, and then came the FFP in 1950s. Thereafter, when we came across clotting factors, and that was the turning point. But the only drawback that we faced in 1980s was the component or the blood-associated infections. So thereafter, again, the recombinant CFCs came across to tide over this problem. And now we have extended half-life. Now, I mean, everybody must be getting baffled what is extended half-life. I would want to just clarify that diabetes is very, very familiar to us. We had evolution of diabetes. We had insulin, we had lentase, we had intermediate acting insulin. Now we have long-acting insulins. So they are giving a complete level. And what we know, we are putting them on long-acting morning and evening. So what is happening? We're getting a beautiful level of insulin cover all the time, and there are no troughs and peaks that we get in the sugar levels. But otherwise, I mean, earlier we used to give insulin with every food and everything, and we were getting a lot of differentiation in the sugar levels, and we had a lot of issues with the sugar control and managing the diabetes. So as the diabetes treatment has been evolved, so has hemophilia. So from normal standard half-life, the already product which we are using now, from there we have moved to the extended half-life. That means they have a prolonged half-life now. So why it is important to have this? Because what we are dealing with, like we have to maintain a sustained level of factor VIII in the blood. So that is why these things have come. So that is the unmet need that we are referring to. So we want to prevent joint damage, because even a single bleed in the joint may damage the joint. So that is why we are targeting a level which is going to be sustained throughout. And most importantly, with our pediatrician, major concern is IV access. So multiple injections we can get away. That is another beautiful part of it. And the effect that we want to offer to the patient is being hampered with not being met with the standard half-life. So this is the recommendation. It is available online at 3rd edition of World Hemophilia Federation guideline, that they also endorse that we should move from this standard half-life to the extended half-life to prevent the in-between bleedings and have a better control of bleeding. So how do we define extended half-life? So most importantly, that we have to just understand for everybody of us to understand that the half-life should be more than 1.3 or higher. So based on the data. So you have, and use this, there are some technologies you're going to extend the half-life, and we are going to talk about it in coming slide. So these are the two products which are available in India. So one is the Turoctogok Alpha Pegol, that is by the Novo Nordisk company. And there is another which is Factor 9, which is marketed with the name of Refixia, Nonacog Beta Pegol. So these are both pegylated products. So why pegylation? Pediatrician, we know that pegylation is very, very common. We use it in vaccination also. So it is very, very, it is there in the market for almost 25 years. It's been used in many of the medicinal products. So it is we are going to the pegylation is done with the factor VIII molecule, and it is being binded with it so that it stays in circulation for a longer time. So what are we have lysosomal degradation. We have lipoprotein, lipase protein associated degradation. These are all being tided over by this technology. So these are the 3 points that we talk about. This is the basic physiology, that because it increases the size of the molecule, the kidneys are unable to excrete it. So this is one of the study which is being done. It is known as Pathfinder. It started in 2010 and it is completed in 2018. It has got Pathfinder 1 to 7. These are all phases, all the various parts of studies which talked about the safety and the efficacy of Esperoct, which is known as N8GP. which is known as the short form of this. So they have studied the efficacy and the pharmacokinetics of this medicine through these trials, and they have found that it is very safe and efficacious in it, and it has really helped in decreasing the number of bleeds and has decreased the number of doses for surgery as well. So if you look at the half-life, the standard half-life of any factor VIII is 12 hours. But for this extended half-life, we have been able to achieve as 1.6-fold increase in half-life, that is going up to almost 19 hours. So if we give 50 IU per kg of the dose to a patient for every fourth day, we are able to keep that patient's factor level above the above the desired level for almost 6.5 days. And patient don't come back to 1% bottom line, so they don't bleed. So if you look at this level, there's only the comparison that they are showing that if you use dose of 50 IU per kg every fourth day, so more than 5% of percentage factor VIII stays in the circulation, that we call as trough level. And if we going to give 50 IU per kg every fourth day, so it in adolescent, the dose is slightly higher because of the clearance. So dose is almost higher, and that also helps to maintain the 3% trough level in the body. So what WFH proposes that if we keep the trough level of between 3 to 5%, the breakthrough bleeds and the joint damage is taken care of. So again, it talks about the same thing, that if we are going to provide the prophylaxis as we give insulin to maintain the sugar level, here we give factor VIII on regular basis to maintain the level so that the level doesn't fall and the patient don't bleed. So what is target joint? Target joint, what we are happening is because a lot of disabilities associated with hemophilia, because even one bleed can cause crippling disease. So if the patient is bleeding in the joint and they get arthropathy in the long run, so that is, and those patients, if they bleed repeatedly into one joint and they're bleeding for more than 3 times in last 6 months, then we call that joint as a target joint. And that is taken care of. I mean, if you're going to take away the long run, what disability happens is if the patient continues to bleed in one joint, the hemosiderin destroys the cartilage there. So and slowly from kind of synovitis, we progress to arthropathy. And that is going to increase the lot of burden, and the quality of life of the patient is compromised. So this target joint is resolved if the patient is put on regular replacement therapy with factor VIII, extended half-life. So when we look at the 5 years data here, so we can see that the bleed is, patient have stopped bleeding over the years. For 5 years, if we look at the data, that shows that almost 64%, the people were able to achieve zero bleed in this section. Most importantly, fewer injections. Otherwise, the standard and regular factors that we're using now, we're giving at least thrice a week injectables for maintaining the level. But with extended half-life, we can get away with every 4th and 5th day. So this is the doses, and what we have seen that with minor bleed, only 1 dose is enough, but with standard half-life, you have to give many a times 2 injections. With moderate bleeds, you can get away with only 1, and you don't have to repeat the other dose as well. With the major bleeds, yes, you have to have a daily dose as long as recommended by the literature. But here, I mean, we see, if we look at the overall doses for the major bleeds, there's a gross reduction in the amount of dose that we require here. So, and moreover, because of the sustained level, it gives a very good bleeding control, which is otherwise slightly an issue when we go about in the major bleeds, and also in the surgical procedure where we want a sustained level to happen. And if we look at that, there are other concerns that we have is the inhibitors. Whatever proteins you are adding to the body, we can have an antagonist in the body. So what has happened with the inhibitors is also when they looked at the trial that previously treated, PTB means previously treated patients who had not come across inhibitors in their studies. So that was, and one of the patients who was reported positive, became negative after following up for 2 weeks. And moreover, there were no safety concerns here because of the pegylation. We have this concern that pegylation or the pegol may have problems with the toxicity in the body. No, it has not shown any side effects. So there are various products which are available, but again, there is a difference in the half-life, though we have another extended half-life available that is there, but still that half-life, extended half-life is only 14 hours. When it comes to extended half-life, that is Esperoct by Novo Nordisk, it has 19 hours. And the trough level, the level going down is up to 5 years. It maintains up to 5 days. And time to 1%, that is going below the severity level, it takes almost 6.5 days. So if we look at it and if we want to see, instead of giving 4-day factors, we can also get away with giving 5 days or 6-day dosing to these patients. So this is a summary overall that it has the half-life extension 1.6, requiring only 1 doses per day for major bleeds. Second part, it maintains the level for more than 3%. Most importantly is that many of the patients with 40 IU per kg is maintaining trough levels for 5% and more. And most importantly, in our country that we can room it at our temperature, but store it at 30 degree also. So which is not there with other products. And another annual bleeding rate that we look at, if we are putting a patient regular replacement, that Optis will be highlighting that part, that we go down in the annual bleeding rate, that is only 0.8% at the end of the study, which they have noted. And the spontaneous bleeds were not noted at all. Like these patients are just walking on the road, they bleed spontaneously, but it doesn't happen if they are on regular replacement therapies. So another factor is the factor 9, which is also extended half-life. This is a very beautiful molecule because it stays in the circulation for more than 5 days once you give the dose. And with weekly doses, you achieve a very good trough levels, and we are able to get away with the bleedings. And factor 9 half-life is prolonged for more than 5 times. So if we have this factor half-life of standard half-life of factor 9 is 18 hours, here it is 93 hours. So here it is this is the most achievable thing that has happened with the extended half-life in case of factor 9. So again, the same thing, when you're maintaining the level in this way, then the target joint resolves. And most importantly, the number of infusion, if you look at the standard half-life. So it's just what we are doing is this level here we are going to use 40 IU per kg. So number of IU which I use is recombinant factor 9, which is standard half-life is 110 doses. Whereas if you look at the number of infusion with extended half-life, it's just 40. So how cost effective it could be. So if you look at the, the infusion, so it's going up to 160 IU per kg with standard half-life, and it gets down almost to 40 per dose if we go about extended half-life. So these are the Canadian experience that is there. There's a multi-centric trial. We talked about hemophilia B outcomes here. So they have seen that there were 42 patients who were there on the extended half-life, and they have observed these patients for 2.3 years. And they have shown the number of consumption which has gone down with the, and of course with the fewer bleeds, if you look at the data. And the annual bleeding rate has also gone down from 6.1 to 2.1. So then again, these are the summary of the clinical benefits that we get. We have 5-fold increase in the half-life, that is 93 hours as compared to the standard half-life. And the activity stays for almost 23.3% with 40 IU per kg. And to go back to 1%, that is at the level of the patient's level, it takes almost 22 days. It's not 22%, sorry, 22 days. And the prophylaxis gives a very brief, you can at least get away with only once in 7 days, or many times depending from patient to patient, you can go up to 1 doses per 10 days also. It varies from people to people. But in surgery, it has a beautiful effect. For minor surgery, what we have used in this patient is that only 1 dose was required for an extensive exploration for a molar extraction, and we did not need a second dose because it achieved a very good hemostatic level. So these are the actual data which is there. So in UP, Noida, they have around 10 patients on this products, and they're using it for prophylaxis, tertiary prophylaxis and surgery. So what they're using is 20 to 30 IU per kg every 14 days. So, but they have achieved good result in their patients. This is all the data from the National Hemostasis Update 2022, which held in Bangalore this year. In UP, they have almost 7 patients on it, and they have organized 2 major surgeries and with good results. And Rajasthan also 12 patients are on prophylaxis with this extended half-life. 10 of them are hemophilia A and 2 are hemophilia B. And 4 on our only episodic treatment. So they have achieved 0 spontaneous bleed, and school absenteeism has also gone down, and inhibitors also not reported. In Maharashtra, there's been only 1 surgery, total knee replacement. Sir's center, sir will share the data himself. So these are other centers as well, if you look at it. So Delhi AIMS also have a lot of experience with that. Gujarat, Karnataka, Kashmir, and Maharashtra, Mumbai, and in KEM hospital. So these are the centers. In Nagpur, our center also have used it. I would like to just share a brief slide of my center, and that would be my last 2 slides.
This one.
We have been getting long-acting extended half-life factor with the help of World Hemophilia Federation, with the help of HFI. And we get humanitarian aid, and mostly we get Eloctate on that. Sorry for the interruption.
This.
Start from here. Start from here.
Yeah.
So we have a database of Hemophilia Society, Hemophilia Federation India. In that, we have approximately 490 patients registered with us. And of that, 419 are factor 8 and factor 9 are 64, VWD are 12, and other 6 in which in this we had 3 Glanzmann thrombasthenia. And some of them, their details are still not shared with us. So that data is missing. And 15 of them have been deceased. So the So we had actually 2 life-threatening bleeds patients in our setup. And I was, very fortunate to treat it with the Apte sir. There was one inhibitor patient with the intracranial bleed, which sir guided me with the therapy. And we could resolve his bleeding with the conservative doses only. Surgery was not required. And that patient, with the help of sir, we had put on regular replacement and immune tolerance therapy. And that patient became inhibitor negative. And thereafter, the patient is on now prophylaxis. And recently he's visited and he has not bled since then. So it's been more than a year. He bled last in 2021, he had this episode. So this is the Eloctate only. That was the extended half-life that we had treated that patient with. So these are the various data that we have. That when there are some issues with the factor supply. So prophylaxis keeps going up and down. Otherwise, we try to put as many small babies on prophylaxis so they don't bleed. And I'm thankful to Meena Madam for helping us through ASIC, because all her ASIC kids are on prophylaxis because of her. The 3 children who are on regular prophylaxis. And those, they have not bled since then I've been seeing. Madam has recently shifted, allowed us to shift that patient on Esperoc, the one who was bleeding with the standard half-life factor as well.
Yes, we have used one EHL factor in one patient.
Yes. So we have this number of patients that we have treated, and the IC bleed, as I said, it gets very good control with the Eloctate extended half-life, and most of them have resolved beautifully. The third day scans have been not progressing, and they do really well, and we put them on. Then we put them on secondary prophylaxis for at least 6 months so that they don't re-bleed, especially in the small babies. So this is the basic experience with hematuria. I think that is one thing I would like to stand out with hematuria. Mostly we try to replace the factor, but I request everybody to please look at the cause as well there. So last patient that we had in the month of September, this was a GI bleed who was, bled very badly, and he came with 2 gram hemoglobin only. And they didn't realize what they do is that we don't understand that we should not be offering NSAIDs to them. After probing a lot, he came to find out from the mother that they've been using NSAIDs and the child was having melena. And because otherwise the child was looking very well. There was no bleed, no superficial bleed anywhere, no distension of abdomen, no obvious localization. And so sending a patient of 2 grams for endoscopy was an issue. We did endoscopy thereafter. That showed ulcers there. But finally, we put them on PPIs, and we could manage that patient conservatively with the factor, and that the child is good and he's from Jabalpur. There's another child of IC bleed that we recently, is a happy smiling face, and he went home in September. So we could do very well with the extended half-life. It had STH as well as intraparenchymal bleed as well. Thank you so much. Thank you for your patient listening. I'm happy to take questions if there are any.
We have a time for the question and answer. If someone has any questions, we can go for that. So we don't have the question. I must thank Kanjukadu ma'am for their lucid presentation on driving change in hemophilia care with extended half-life factors, and introducing us with the various extended half-life factors like turcotococ, alpha pegol, and non-coc beta pegol, and letting us know that these factors help us in improving the potency and the compliance for the treatment in the hemophilia care. Thank you so much, ma'am.
Thank you everyone for being patient. Thanks a lot.
I have one question. As I am in admin, I want to know, does we provide that preventive prophylactic dose? Is it routinely advised? It is as per norms, or on demand wala hi factor dete hain?
No, actually, madam, as per sir will be talking about it, that only treatment for hemophilia now is prophylaxis or regular.
Yeah, but does Maharashtra government?
No, they are not doing it, madam. No. That is what we are supposed to work for.
None of the states except Kerala and Assam are providing prophylaxis. And Kerala has gone one step ahead. They are giving a home therapy. The home therapy should be the correct way of prophylaxis, because to travel once a week to the center for 50-100 kilometers, the compliance definitely gets affected. That's what we thought. But recently, last 5-6 years in our center, we are routinely doing prophylaxis through World Federation factors. And many times we get high denomination vials, like 2,000 units, 3,000 units. So we share the vial. So we have timings, and that group of patients come, and because the factor is stable for 4 hours. But yes, prophylaxis is the way, and there is a great advocacy going on in for prophylaxis and home therapy for hemophilics.
Our patients at ESIS are very fortunate to have a prophylaxis dose, but I think all children are not that fortunate to have prophylactic dose in.
No, but through society, whenever we get humanitarian aids and we know the lot stock isn't coming, we have chosen We have at least 8 children who are regularly coming to the center.
Yeah.
So I try to manage somehow that their prophylaxis is not broken,
Yeah.
because I don't want, I mean, most of them, especially the ones who have bled recently, they are my priorities, and the ones who have not bled at all, they are my ultimate priority, because they should not even have a single joint damage. That should be our everybody's aim. And that's the way we want to work and we want to achieve the goal. Thank you.
Thank you so much.
Thank you, chairpersons, and thank you, Dr. Anju. I request Dr. Dange sir to kindly felicitate our chairpersons. Dr. Meena Deshmukh madam. And Dr. Pritesh Khatwal. And also Dr. Anju. Please. अरे ले लो अंजू ले लो. So with this, we move on to the next session. That is, that will be given by Dr. Shashikant Apte. Prophylaxis, the only way to treat hemophilia. And for this session, I invite chairpersons, Dr. Avinash Profi, who is a senior hemato-oncologist of Nagpur. He's a director of Central India CIHO. And also I invite Dr. Rahul Arora, who is assistant professor at AIIMS Nagpur. He's been trained at Sir Gangaram Hospital and also has experience of almost more than 120 bone marrow transplants. So over to you, chairpersons.
Very warm winter morning to everyone. So today we have an eminent speaker with us, Dr. Shashikant Apte with us, to enlighten us about prophylaxis in hemophilia. He's a MD General Medicine FRCP Hematology from Royal College of Pathologists of Australia. He started his bone marrow transplant program in Pune and has experience of more than 600 bone marrow transplant, of which around 100 are allogenic transplant. He has various research projects in hemophilia, many research papers, Vice President Medical Hemophilia Federation India for 6 years. We all welcome Dr. Shashikant Apte to deliver his talk. Over to you, sir.
Dr. Rahul, for those kind words, and it's my sincere thanks to Dr. Anju and her team to have invited me to give this talk. Hematology is a very diverse situation. On one end, we do situations like bone marrow transplants, hemato-oncology, leukemias, lymphomas. And let me honestly tell you, according to me, hemophilia is a more malignant disorder than many of the hematological malignancies. It's an extremely aggressive disease and needs a very, very aggressive management. Otherwise, you are going to lose the patient. Treating malignancies, you get time. Treating hemophilia, majority of the times, you may not get time. It is very important to have proper understanding, proper organization. And let me tell you, it doesn't happen overnight. It has taken years to organize the group. Like I'll just give an example. 2 days back at 4:30 in the evening, a child came severe hemophilic with vomiting, no other symptoms, no other this thing. He's a 10, 12-year-old, our own patient. No physical findings, no localizing signs, but it is our dictum that unexplained vomiting. We immediately got a free brain CT, plain CT, and he had a huge subdural hematoma with midline shift. Child hit the hospital at 4:30. By 7 o'clock, he was on operative table and he was rescued. He's doing very well. Today is day 3 post-op. It is important to understand how we treat hemophilia. when 10, 15 years back, so when some government support started opening, we realized what mistake we had done while writing our textbooks of hemophilia. When we said, give us prophylaxis, I remember then health secretary said, Dr. Apte, your own textbook says give on-demand therapy. So now over a period of time, this distinction has been made very clear. And I'll try to take you through some of our experiences with low-dose prophylaxis. So basically, if we have to improve the health of hemophilic, the only way is to prevent bleeding. 5 ml blood is enough to cause a joint damage and set the inflammatory reaction and cause overall worsening of the joints. So prevention of a bleeding is the most important way, and that only can be done by prophylaxis. And we have to keep in mind that this is a long-term management. If we are planning prophylaxis, we must have certain prerequisites. And most importantly, you should have to have a trained team. I personally feel if you do prophylaxis without monitoring inhibitors is incorrect. What happens that when on-demand therapy goes on, inhibitor testing happens erratically. But whereas when the prophylactic program is going on, we do inhibitor very stringently and we pick up inhibitors at an early stage. And that leads a wrong conception that prophylaxis causes inhibitors. It is not that. The patients on prophylaxis have a better follow-up. Patients on demand therapy come erratically. There is no regular follow-up of these patients. And that is the major difference in prophylaxis and on demand. Any chronic management and expensive management like hemophilia has a lot of barriers where we can adhere to the given protocol. And these barriers are multifactorial. Some of the barriers we can tackle at physician end, medical end, but a lot of barriers are at the end of the administrators. And it is very important for medical fraternity to train our administrators. They are administrators. They don't know. We have to educate them. And the way of education is always prolonged. It doesn't happen overnight. Even we take 10 years to pass SSC. We don't pass SSC in the first year of our school. And I keep telling my colleagues, have patience, things will change. I'm in this field since 1990 as a trainee, since 98 as a consultant. I never thought that time that any government would support a disease like hemophilia in India. But now more than 23 states are giving some support. The figure is crossing nearly 2 billion rupees worth of products all across the country, which is inadequate. We need around 8 billion rupees worth products if we want to treat all our hemophilics. So when we talk of ideal therapy for hemophilia, it should be safe, it should be efficacious, it should be accessible, available, and acceptable. There are certain cultural challenges which a treating physician may face while treating hemophilia. And most important thing is to the zero development of inhibitor. Inhibitor is a nightmare to manage in patients with hemophilia. As Dr. Anju showed, we start treating hemophilics right from the young age, and number of injections becomes a very crucial issue. Extended half-life products, especially extended factor 9 product, is a great product. Factor 8 extended the half-life by 6 hours. The 12-hour half-life went to 18 hours. It was not a great impact. It was the impact in surgery. But factor 9, the half-life is 5 to 7 days. In fact, I'll show our own data, which is now published. The prophylaxis for factor 9 has become much easier with extended half-life products. We have seen a great evolution. Dr. Anju showed this slide, and we moved from whole blood to extended half-life products. Now we know newer drugs. We are planning one of the patient to be cured of hemophilia. We are planning in next 15 days a liver transplant for a 21-year-old person who is Hep C positive. His alpha-fetoproteins are rising. So that has become the indication for liver transplant. So we are working up this patient. If that happens, it will be the second liver transplant in the country. And we are talking of cure now. The gene therapy is definitely at the doorstep with our clinicians. And I'm sure the things will change in coming 5 years' time. So this is a beautiful slide to show how the paradigm shift has happened in the management of hemophilia from products which are short half-life to extended half-life to non-factor therapies and now to cure with gene therapy and liver transplants. So today's concept of hemophilia management is ABR, annualized bleed rate, should be 0. If you can reach ABR 0, then the child can really live a normal life. 3 years back, a severe hemophilia B from Germany conquered Everest. He climbed Mount Everest. There is a severe hemophilia A patient who participates and completes Tour de France. That kind of quality of life and aspirations hemophilics are carrying. And it is possible. It is possible even in our country. One of our severe hemophilia A with factor inhibitor is in Maharashtra swimming team. Swimming is the best exercise for hemophilics. And we really promote swimming in our own center with prophylaxis. Prophylaxis alone is not enough. I don't know how many of you have seen Sahyadri, but next to Sahyadri is the national level swimming pool, and all hemophilics get a free membership at that swimming pool, and a lot of children have been benefited by swimming exercises. So as I showed, and as I said, 15 years back, this health secretary taught us to differentiate between treatment of hemophilia and treatment of bleed. When we are using acute replacement on demand, it's a treatment of bleed. It's not a treatment of hemophilia. So on-demand therapy is not a therapy for hemophilia. It's a therapy for bleed. And prophylaxis is the treatment of hemophilia. Inga-Marie Nielsen was the founder of concept of prophylaxis. Very small database she collected from 1968 to 1992, huge span. Initial part was with cryoprecipitate, later on with plasma-derived products. And she showed that at 25 years follow-up, there was excellent joint prevention when prophylaxis was used. So basically, there are certain issues with prophylaxis. When to start? Very few people are having primary prophylaxis. Primary prophylaxis means prophylaxis happens before the bleed has occurred, before the first bleed. So generally, people are not following that policy because of the venous access issue. But once the child has had first bleed, you have to start prophylaxis before second bleed. It has been clearly shown that you start the prophylaxis early, the long-term joint prevention and joint damage is less. Prophylaxis has to be cost-effective. And there, the extended half-life product, especially extended half-life for 9, has made a huge difference. But most important thing is that there should be a continuous supply and a predictable supply, which is the issue in our country. We really got taste of prophylaxis when World Federation Health started in 2016. And we have generated excellent data in this period. So when we talk of prophylaxis, type of product becomes important because of the number of injections. The definition of prophylaxis is that for at least 46 weeks in a year, the child should have received regular products. If it is less than 46 weeks, there is a huge difference in the fellows who have received prophylaxis for 40 weeks versus 30 weeks versus 50 weeks. The difference is very clear-cut. We should have a proper hemophilia treatment center till we start home therapy. And let me honestly tell you, home therapy is the best way. In our center, we have been encouraging, and through World Federation, when we could manage, we have given home therapies, and that really helped during the COVID days. COVID days, the prophylaxis really went on for toss, because traveling had become quite difficult. But the fellows who could do home therapy really did well even during the COVID period. And willingness of the patient and parents. Because when in the era where we are not able to give prophylaxis, to come at least once a week to the center to take factor needs motivation. But when they realize that child is bleeding less, they don't mind coming. So 3 days a week, we have split our patients. Thursday, Friday, Saturday is our prophylaxis day. And once we do that, it also helps us to generate data. Because we know from 9 o'clock in the morning till 1 o'clock in the afternoon, we are going to see some 30-35 hemophilics coming for prophylaxis. That also helps to generate your dynamic data online. Because retrospective data collection becomes quite difficult. So we have patients where we know exactly how many exposures they have had, exactly how much factor they have received in previous year, how we can promote the new year policies. It really helps out. And that really becomes important with prophylaxis. With prophylaxis, the physiotherapy program goes on well because they are visiting center. There is an intermingling, there is a social interaction of various patients, and they get motivated hearing the stories of other patients. So these are the various ways of prophylaxis. As I said, primary prophylaxis now is defined as before the second bleed. Secondary prophylaxis is after the first bleed, after the second bleed, but without much joint damage. And tertiary prophylaxis is basically with joint damage. We use a lot of tertiary prophylaxis before joint replacement surgery. Because even at age of 40, we have seen patients who have never received products. They are pups. They are previously untreated patients. And they get referred for joint replacement. These patients are all joint replacement patients. We put them on prophylaxis at least for 8 weeks prior to surgery, strengthen the muscles, and then take them for surgery. And in this group, we have had nearly 11 patients referred above age of 40 for joint replacement who were pups. Everybody developed inhibitor. And that is another way not to take inhibitor patient to surgery like TKR or THR. So we are able to give them a breathing pace. We also get a breathing pace to realize whether they are developing inhibitor. And let me tell you, adult pups, when exposed to factor 8, they are going to mount more response, more inhibitory response. So what models we have today available in the world? So the best work has been done by the Swedish group from Malmö, Inga-Marie Nilsson group. Now Dr. Erik Berntroff heads that unit. They use high-dose prophylaxis. They're using 6,000 IU per kg per year, extremely expensive. So virtually 1,000 IU per kg per week is used. We have 52 weeks. We are crossing 5,200. So it is more than 1,000 IUs per kg per week. So you can imagine a 50 kg person would require 50,000 units per week. 50,000 units per week into 52 weeks is huge. And that kind of cost we cannot afford. The Dutch group always has been conservative among the hemophilic community in Europe. And they have always proposed that we may not need so much. And they came out with this intermediate dose protocol, which comes to around 2,500 IU per kg per year. And our group, we have started using more than now 7-8 years, around 1,000 units per kg per year. That is possible. That is doable in our country. Even with the government setup, we can do it. We showed it to the government of Maharashtra that so many patients from Pune, we could collect better data that have used these products. And I'm going to share that data, what we showed with people, with the government authorities. And it is not very expensive because that's a misconception that prophylaxis will be more expensive than on-demand therapy. So in Indian scenario, where we are 1.3 billion population, the estimation is that in another 7 months, we will cross China in the population. And we have only around 29,000 diagnosed hemophilics. So we have not diagnosed nearly 80% of our hemophilics in the country. At the given time, we are having a per capita consumption of product is one of the parameters how you assess the hemophilia treatment. So today, general arithmetic shows that it is 0.19 IU per capita. But we must understand this 0.19 IU per capita gets converted into 1 because we are only treating 20% of our total population. So actually we are reaching effective IUs per capita to 1. And once you reach effective IUs per capita to 1, it is possible to give good prophylaxis in a given scenario. So these are the definitions, various definitions of or parameters. I won't call definitions, parameters of hemophilia, and they're available in third edition guidelines of World Federation. So there are challenges. First thing, before you start prophylaxis, the hemophilia physician has to really sit down with the family and explain them what it means. Because you take prophylaxis for 10, 12 weeks and suddenly drop out, it's a great waste of a product. You should not waste this kind of a product. We have to explain that this is not a clinical trial because we are trying to use in a given setting. There is a possibility of an inhibitor development and strict monitoring of inhibitor is required. Let me honestly tell you, people also have been in hemophilia field, majority of the hemophilics are poor. And you have to really support them financially even to monitor these parameters. Dr. Rajesh is here. We have been working in inhibitor group, and let me honestly tell you, as your workload increases, the cost of inhibitor comes down. Because inhibitor, unless it's an emergency surgery, you don't want inhibitor report in 4 hours or 6 hours time. So we run it in a batch. So when we do it in a batch, the cost really comes down. But yes, a lot of people, a lot of pathologists carry fear of the tests. And let me tell you, all hemophilia tests are nothing but APTT. It's the various ways of different permutation combinations and doing APTT. If any lab is doing decent APTT, can be an excellent coagulation lab. And I keep telling all the people who approach us how to organize. Hemophilia should not be the cause for setting up coagulation lab. Your other workload is a reason for coagulation lab, and hemophilia is an excuse. Even today, when we audit ourselves or we look at our workload, our 80 to 85% of coagulation workload is for non-hemophilics. Obstetric, pediatrics, surgery, cardiothoracic surgery, neurosurgery, hematology. They need it. If we do 70, 80 PT APTTs per day, hardly 10 are for hemophilics. And because of this kind of a proportion, we can really do huge charity on hemophilic patients. We can write off. Like today we are the lab for the Western India to monitor blood bank quality control. So we roughly do around 90 to 100 factor 8, factor 9 von Willebrand assays for various blood banks in Western Maharashtra. So every week we have 25 samples running for factor 8 and factor 9 assay. What is there to do 1 or 2 factor 9, 8 assays free for hemophilia? But that happens because of the volume. Once you start having you have a good volume, Dr. Anju, your registered patients are more than our patients in Pune. We have a lot of referrals from outside Pune. We don't consider them in our regular database. Your number is more than us. You can do a very good lab, and some of your pathologists and technicians recently had training with us. So we have been using low-dose prophylaxis and we are sticking to extended half-life product. We are using products supported by World Federation, which is FC binding EHL, whereas Novo's products are pegylated. There is no great difference. There is no head-to-head trial, but these are the dosages we are using. The literature recommends 40 IU per kg once a week for factor 9. Madam, I am leaving the slides with Dr. Anju. You can copy the slides. Take the slides. Therefore, everybody's use. Okay. So we use 20 IU per kg once in 2 weeks. So in fact, we are giving 1/4 the recommended dose for prophylaxis. So 40 IU per kg per week, we are gone to 20 IU per kg once in 2 weeks. So it is 75% reduction. And we also use same dose for continuous tertiary prophylaxis and intermittent prophylaxis. This is our data for continuous tertiary prophylaxis from January 2017 to January 2022. The initial data at end of 2020 was published. We have 84 patients aged between 3 to 11. We slightly had a selection bias. We purposely kept a selection bias that the median exposure was at least 20. So the median exposure was 22. The idea was that we know today the incidence of inhibitor development is maximum in first 20 exposures, then up to 50 exposures. And once you cross 50 exposures, the incidence is really, really low. We didn't want too much of inhibitor in our hand to manage with prophylaxis. So anybody has a newly diagnosed hemophilic, we did not include in the prophylactic arm till he completed 20 exposures and was shown to have no inhibitor. So median ABR was around 14. At least they had 2 target joints. And no single joint had HGHS, that is hemophilia joint health score more than 5. Well, it has been again documented. Once you have HGHS beyond 5, the prophylaxis does not prevent bleeds. Because the synovial hypoplasia is there, the synovium is very fragile. So once you cross HGHS 5, the joint advantage or benefit is less. So we selected these patients out. The median days missed in the previous to starting prophylaxis was 26 days. And all patients had more than 36 months follow-up before publication. Inhibitor screen was done at every 10th exposure day, up to 50 exposure days, and then after every 25th exposure, till life, till in dynamic way. So this data collection is very important when you are doing prophylaxis. And this is the data. 4 patients developed inhibitor in this group. 3 had low titer transient inhibitor and continued with prophylaxis. 1 patient developed a high titer inhibitor and he was switched to ITI. He responded to ITI and he is on an intermediate dose of prophylaxis now. Total breakthrough plus post-traumatic bleeds were 118 over 5 years period in 84 patients is negligible. It is absolutely negligible. And extra dosage of Eloctate used to treat these bleeds over 5 years has been only 144 extra dosages. So total Eloctate used over 12 months was somewhere around 1100 IU per kg over 12 months. And the trough level was maintained at around 2.6. So basic concept that you convert a severe hemophilic into non-severe hemophilic. But again, there is a phenotypic difference. Some of the patients may have level of around 1.8, 1.9, but will still bleed. We share the vials, and that's why it's a majority of the prophylaxis is institution-based and not a home therapy. Some patients we are shifted to home therapy where the dose is something like 500 units or 750 units. Because if the dose is coming to 200 units, we are giving 200 units. We are not giving excess. We are trying to maintain for more patients. And this is the outcome analysis at 48 months. Annualized bleed rate, which was median at 14, dropped down to 1. HGHS improved, fish improved, and days missed. There was a dramatic drop in this group. At the same time, we had some 48 patients who were on a continuously coming on for demand therapy and didn't want to come for prophylaxis for various reasons. We used them as a control group. And they used around 850 IU per kg per year. So difference of low dose prophylaxis and on-demand therapy is only 250 IU per kg per year. So it's a very negligible difference, even administratively, to provide prophylaxis. And this is the comparison. On-demand therapy really did not benefit in any of the parameters. That is ABR, HGHS, fish or days missed. And prophylaxis came out very strongly as far as the improvement in all these 4 major parameters of hemophilia were concerned. This is the data on Alprolix, that is long-acting factor 9. It is 20 IU per kg once in 2 weeks. And we are using somewhere around 500 IU per kg per year, because it is only 2 shots a month. So 24 shots, half the dose of factor 8. And this was a presentation in World Federation Congress. Again, a marked benefit in all the 4 parameters when you compare over on demand. The trough level of factor 9 was maintained at around 3.4%, which is excellent. Really good trough level, really had very less breakthrough bleeds. And the first data has been published in 2020. So basically, I won't say these are the conclusions, but I call them impressions, because things may keep changing. We have, ideally I feel, we should give 2 IU per kg per day, IV. We have 2 twins who are severe hemophilics. We are able to share vial. They're taking therapy at home. They're taking 2 IU per kg per day. So it comes to 14 IUs per kg per day, 14 IUs per kg per week. It comes to around 700 IUs per kg per year. And believe me, these children have not bled in last 2 years, but daily they have to take IV injection. That's only the hassle. And now the trials are going on with subcutaneous injection once a week. The next step of product is extended half-life, subcutaneous once a week. Once that comes, it will really make a huge difference in hemophilia management. The emicizumab prophylaxis has made a huge difference. It is subcutaneous. It is once a month. And slowly the paradigm shift is going to happen. And it is already happening. And whatever we say and do, we must thank the pharmaceutical industry, especially in all fields of medicine. Without development of drugs and products, it would have been impossible to treat, forget hemophilia, any other disease. Even simple headache would have been difficult to manage without the drugs. So if we want to change the natural history of hemophilic arthropathy, that is recurrent bleed, synovial disease, dissection arthropathy, and severe disability and joint replacement requirement, to prevent that, the only way is to do prophylaxis. That's the way we can achieve. And there's n number of data. You can use 6,000 IU per kg per year on-demand therapy. At end of 20 years, there is no improvement in the joint. The joint score is still bad, because 5 ml blood is enough to create a joint damage. And yearly outcome assessment has to be done. In our center, we are able to complete around 60% of the patients to have these all parameters tested at least once a year. That's a huge data. That's a huge data. And if we systematically do, I would strongly suggest, Dr. Anju, have a data manager with you for your entire work. We have 2 data managers. Between them, they share our hemophilia data. Again, as I said, it's an excuse. Hemophilia becomes an excuse because it's a poor man's disease. Our data managers primarily do because now we have crossed nearly 800 transplants. We have a very busy oncology unit. They maintain that data. And I use them for our hemophilia data. The hemophilia is always an offshoot. It cannot be the primary intent whenever you want to develop any development in your own institute. But believe me, if you can monitor these, even on 20 patients, those 20 patients will be immensely benefited in long run. So low-dose prophylaxis really gave an opportunity to dream to be fulfilled. It was a great opportunity because of the World Federation program. But with this data, now we are advocating, doing advocacy programs with various states. Now we have data. 5 years back, we had no data, Indian data on prophylaxis. So it is helping to a great extent. And some of the states are definitely changing. And the classic example is Kerala and Assam. And NHM chief at Kerala, Dr. Sriyar, is so proactive. He has been a great individual to talk with, and he is very adaptive. And Kerala has now 200 children on home therapy with prophylaxis. We have to start prophylaxis as early as possible, so that they may have a better joints when they enter teenage. They do not have teenage with the joint damage. less dose is required. Initially, you may have to share the wires, but once the home therapy comes, we can go to the individualistic treatment. With that, I would thank for your kind attention, and I would like to have any questions if you have. Thank you.
Good. Thank you, Dr. Shashi. It was a very good lecture on low dose prophylaxis. We appreciate that. Any questions?
Sir, good morning, sir. Dr. Deshmukh here, sir. I work in Daga Hemophilia Daycare Center in the government setup. As you rightly said, sir, prophylaxis is the way we have to treat the hemophilic. But unfortunately, you know, the cost factor and the allocation of the factors to the all hemophilic in Maharashtra is a very difficult task. As I want to ask you, sir, what is the hurdle in the Maharashtra government? Because we are also pursuing, we are requesting to give prophylactic factor dose at least for the pediatric population, so that even if we get less factors, but unfortunately we are not getting permission. And second thing I want to ask regarding this long-acting molecule, why the government of Maharashtra is not purchasing? Because we already requested.
Fine. So first thing, let me honestly tell you, if you see, all our prophylactic patients are below age of 10 years. We do not start prophylaxis above age of 10. For simple reason, we don't have adequate factor to. So 10-year-old child roughly has a weight of 30 kilos. So our cutoff is either 10 years or 40 kg when we start prophylaxis. It is unfortunate. The sheer answer is unfortunate that Maharashtra government we are not able to convince. Other thing also I would say that turnover at the decision-making people is so vibrant. Like Dr. Srihari, I'll take a name. He's there in Kerala at the same position for last 6 years. He has visited our centers out of his own interest. He has visited government centers. He has visited CMC Vellore. That kind of proactiveness somehow we have not seen in certain big states. Some of the smaller states are really doing well. Probably the number is less. In fact, 7 years back, we suggested to government of Maharashtra that we have 30 districts. Our data managers split all Maharashtra-based hemophilics district-wise. And we gave that data to government. Look, Buldhana district has 40 patients. Usmanabad district has 72 patients. Keep some factor in district hospitals. Because if we are on demand and if you have to travel beyond 100 kilometers to receive on-demand therapy, believe me, it's useless. Like first center in Vidarbha started in Amravati. A child bleeding on the border of Chandrapur and Telangana to reach Amravati is going to take minimum 12 hours. That on-demand therapy is useless. Instead of that, if Chandrapur District Hospital had product, and Chandrapur has somewhere around 80 patients. So if we, and let me honestly tell you, we can do that in given provisions. We don't need extra money. See, I'll take an example of Chandrapur. Chandrapur district in the database has some 88 patients from the district of Chandrapur. If we say 1,000 IU per patient per head for 1 month, we need around 80,000 units per month for Chandrapur. 12 months, we come to around 10 lakh units. What is 10 lakh units? They can definitely give. We are using that much. I should give, you are doing this. Just split it equally. Only still 9 centers or 10 centers are there in Maharashtra. That is crazy. Like Aurangabad is the only center. I'm talking of the government system. I'm not talking of HFI chapters. They are the separate out of it. But believe me, I firmly believe ultimately hemophilia treatment has to happen through the government agencies. Yes. It is far more expensive. Far more expensive. And what was your second question?
What should we do in the government setup then to convince, or what are the things to be done?
Advocacy. We have to keep talking them. Keep talking them. Keep talking them.
Sir, you presented very well, and the data that you presented was clearly shows that the prophylactic treatment is of great use. But is there any document or a data which shows a cost comparison between the prophylaxis and the on-demand plus prophylaxis management, because that is what the government always needs. Maybe that the cost is quite high when we give prophylaxis plus on-demand therapy, but if the benefit is more than that cost, the government can think over it. So I think that document is very important document which we should have.
That document is there. Actually, on-demand therapy, there is another side false. The incidence of inhibitor is more in on-demand group. Because when you are giving prophylactic factor, the immune system is constantly exposed to the antigen which is missing. So immunity does not get chance to get upregulated and mount a response. So there was a 40% difference in inhibitor development in patients with yeah. So on demand, it is 850 units only for the factor. Here the cost for inhibitor is not included. If you add cost of inhibitor, it will come to the cost of nearly 2,500 IU per kg per year cost of factor. That has been shown. If you go through the World Federation guidelines, the 3rd edition, it's a 158 document, it's a free download. Clear cut, all this data is available there. We have given it. In last 12 months or 13 months, twice the authorities have changed. So again, we have to restart. Again, I'll tell you, I was involved when we did advocacy in Kerala. It was a completely different experience. We did advocacy in Orissa. I went to Orissa. Orissa government is giving to all district hospitals. 2 weeks back, I have been involved with Jharkhand group. All district hospitals in Jharkhand now have factor available. These small states are doing it, why we are not able to do, is the question.
I think the way you have presented or the way you are moving ahead, even we can jointly put these things in front of the government. And there is a special, we all know that there is a blood cell unit.
Correct.
So
Other thing I will tell you very honestly, that I come from a non-government background. That also carries a taboo with the government. Let me honestly tell you. Jharkhand, Odisha, Kerala, they invited me. I was on the Maharashtra government committee 5 years back. But then they said, only government hospital officers will be on the fine. I said, no issues. If you want, I am there to advise you. Today, after pre-COVID and post-COVID, roughly 10 to 20 weekends, and I mean weekends means Friday, Saturday, Sunday, I am in different states trying to help them out. Last week I was in Ranchi. We had a meeting of all district hospitals because we implemented this program from January, and now our data system they are using to trap the data. And we had an interactive session with government doctors. They were also very happy because they have been involved in something new. Every time I personally feel that people are not interested in money. They want to have a challenging work. See, the one district in Jharkhand has 12 patients. All those 12 patients are on prophylaxis. See, there is underdiagnosis. Jharkhand, even Maharashtra has extreme underdiagnosis. We did a Maharashtra-based survey with KEM for inhibitors. Even Nagpur, we had 2 camps. It was free for the patients. We have 3,500 patients registered in Maharashtra, hemophilia A plus B. Maharashtra population is 11 crores, that is 110 million. So we should have 11,000 hemophilics in Maharashtra. It's a simple equation. We have not reached even 1/3 in a state like Maharashtra. That's the tragedy. See, it is doable. And let me tell you, you do not need more money. Whatever money is allocated, we can do that. We can do that. The problem is, it's not by choice that they are doing. See, when you do something by choice, see, though I'm in private practice, our entire hemophilia services are free in Sahyadri. But we are happy to do it. We are enjoying it. And that has been the policy for the last 24 years. We have done bypass surgery. I'm going to show in my name. I've requested our cardiothoracic surgeons to write off the charges. We never charge. And there are people like this, like Anju. I know Anju Center because we have been so interactively involved. And though this is my first visit to Nagpur, I know what has happened in Nagpur hemophilia because of the interaction. I told her, anytime you call me, I told her that generally my sleeping time is 2 a.m. I'm awake till 2 a.m. in the night. You can call me because when she called me, it was nearly 12:31. She was so, I said, Anju, don't worry, you can always call me. There are people in government. I won't take a name. He was an extremely nice man. He was transferred 4-5 years back from that position. He was very, very clear about how to select the product. Selection of product is a key issue. What product have you selected? And I'm very happy that now there are multiple companies. 10 years back, only 2 companies had the monopoly. But some of the products do not fulfill certain criteria. Should we promote them? The answer is no. We cannot promote.
Thank you. Thank you, Dr. Shashi. Extensive administrative discussion, but it is a vital thing. You are doing a good job in approaching and giving guidance to the various state governments. It is basically a neglected. It is a small community and it needs substantial efforts with dedicated people like you.
I'll tell you, Dr. Avinash, I would differ here. There are only 29,000 patients in the country and they are getting nearly 2 billion rupees for the from various government agencies.
So it is not
sickle cell and thalassemia numbers are far more, and treating sickle cell thalassemia is much easier than hemophilia. Still, they have not got that attention.
Good. So just I got some basic questions. Will there be any occasion to transfer these patients on prophylaxis to on-demand therapy, and in which circumstances? And secondly, what is the status of emicizumab in India?
See, basically, we stop prophylaxis when the product is not available. Okay.
So that is logistic. I'm not interested in logistic. Other than that.
Okay. Second thing, once the patient crosses weight of 60 kilos, we stop prophylaxis. Because from that weight of 30 kilos to 60 kilos, they have got prophylaxis. They have got good joints. We say that now go to physiotherapy, go to swimming. So our prophylactic program is coupled with swimming, is coupled with physiotherapy. There are nearly 70 patients who are enjoying free membership at the swimming pool next door to Sahyadri. And 2 of them are in the state team. One has got selected in the national reserves. So that is one way. Second way, when it is not there, like during COVID times, the World Federation products stopped coming because there was no airlines taking off. The product was there in the godowns, could not reach us. We had to ration it. So there was a break in prophylaxis that time. And sometimes when they developed inhibitor. Once they develop inhibitor, we go to IT.
Emicizumab.
Emicizumab, I feel, is a great drug for prophylaxis. The recommended dose is 1.5 milligram per kg once a week for 4 weeks. Then you can go to 3 milligram per kg once in fortnight or 6 milligram per kg once in a month. We have got now 13 patients, 3 with inhibitor and 10 without inhibitor on emicizumab prophylaxis. We straightway start at 3 milligram per kg once a month. No loading is done. And they're doing extremely well. We have sent a data for publication to Hemophilia. We have got some review changes and probably by May, June, it will get published. We'll get the acceptance this month once we do that. But I'll tell you, we do not have to follow the dosages these companies show because in a controlled clinical trial, like they showed 80 IU per kg of factor 9 single dose for major surgery. We use 80 IU per kg single dose for TKR, during TKR. Day 5, we give 40 IU per kg. and we don't give anything for what they showed in day 10 and day 14. Because after day 5, 60% level is good enough to maintain the wound healing. And that has been recognized again in the guidelines, which again I'll show in my next presentation. So basically, we must understand the clinical trial is a controlled program. You cannot deviate in a clinical trial. But in routine practice, we can do that. And we should do that.
Taking help of the clinical trial as frame of reference.
Correct. Absolutely correct. So that's why I said, when we started this prophylactic program, we told them, look, we are starting 20 IU per kg for factor 8 once a week, 20 IU per kg once in fortnight. This is not a clinical trial. Okay, because it is available, we never had any factor. So we want to see it if it works. And there is a gut feeling it will work. Actually, we had 5-6 patients from ESIS who were already on low dose prophylaxis.
Just a curious question. How many private patients are there with you taking these type of prophylactic treatments?
See,
That is a crisis in the private field because most of these patients are poor. So unless they are under some program which supports them, how many private patients who are paying for themselves?
I'll tell you. Patient is never private. Hospital is private or government. Patient is patient. Whether they come from economically sound background, we have seen we have only 3 patients out of around our 480 patients who can afford anything. They will afford gene therapy also. Only 3 patients. There are some patients, especially from IT, they will afford prophylaxis till the child becomes to 40-50 kg. After that weight, they won't afford. We have done this data. And remaining patients deserve every help, even for any blood test.
Yeah.
So now, for the inhibitors, we are doing factor assay. It's done free in Sahyadri for these patients. But we have a database. We have a certain group which supports us financially.
So the bottom line is something is better than nothing.
Yeah, absolutely. No, the bottom line is whatever prophylaxis you can do is better than high-dose on-demand therapy.
Definitely, sir.
Because the Dutch have published randomized data. High-dose factor 8 replacement on-demand policy versus lower dose prophylaxis cohort over 20 years. Better joints, less joint damage, better HGHS score, better fish score, excellent outcome.
And we have come very far after pushing the government, and we should keep pushing hard.
Absolutely. They're changing. Let me tell you, there is a change. I mean, we should not give up the government. Is not allowed. It will happen. Only thing, the process is slow.
Thank you, sir. Thank you for an excellent overview of hemophilia.
No. See, the prophylaxis has to come from World Federation is supporting. So you can call it an NGO is supporting. Not Maharashtra, entire world is supporting. And World Federation's 25% of support comes to India because of the numbers. No. See, they will not provide for an ongoing treatment. Tata Trust provides 10 lakh rupees for transplant. It's a one-time treatment. It's a one-time. We are doing regular thalassemia transplants. We get various helps from various. It's a one-time treatment. Let me tell you, if you calculate this, if I am using something like, say, 50,000 unit on a child in a year, today's MRP, it is straightway coming to 3 lakh rupees per year. So 30 years, even at weight of 30 kilos, it goes to 90 lakhs. No trust will do that. And I personally agree. We should not do that.
Thank you so much, sir. I have a comment here to make, sir, because here, there is some organizations and the foundations which are giving the factors for prophylaxis and as donations, like INTAS Foundation is there, DHL is there. They through Federation, many of the organizations are working and they are giving us CSR funds for the same.
See, if they are funding, that's well and good. I'm not saying they should not do. But general policy of any trust will be to give a one-time expense or an infrastructural development expense. And I personally feel we should use these private funds coming from private agency for advocacy, strengthening the data, because government will not do that. Government will say we are given 60 crores of worth factor, use it. We should use these funds for other things. But if somebody is willing to give some, like Coal India is supporting 200 patients below age of 10 years every year with prophylaxis. This started around 5-6 years back when I was a VPM. But they said, the rest of the things you have to manage. Don't expect us to give support for prenatal diagnosis, support for this thing, that thing. We are doing this. So every trust, every donor has a different mandate. आपण याचक आहोत, दाता नाही आहोत. So we take whatever we get. But we try to make best of it.
So thank you, Dr. Apte and chairpersons. I request Dr. Vinky Rubani to kindly felicitate Dr. Avinash Prophy. And Dr. Rahul Arora. And Dr. Shashikant Apte. He has one more talk. We'll keep doing it again and again. Thank you, Dr. Rubani. With this, we move on to the next topic, which is diagnostic hemostasis, new challenges and expectations. And to chair this session, I invite Dr. Richa Juneja and Dr. Rajkumar Rathi. Dr. Rajkumar Rathi is a senior pathologist who is at Lata Mangeshkar Hospital, Purdy, and he has received special training at Sahyadri Hospitals as well. Welcome, sir. And Dr. Juneja, she is at AIMS, Nagpur. Over to you, chairpersons.
Good morning, everybody. Today we have got a speaker, Dr. Rajesh Patale from Pune. Dr. Rajesh Patale is a postgraduate in pathology. He has got specialty training in hemostasis, molecular biology, and quality management system. His areas of interest is bone marrow pathology, bleeding disorders, and electrophoresis. He is also an NABL lead assessor. His current position is he is a consultant pathologist at Sahyadri Specialty Hospital, Labs, Pune. His achievements are poster presentations on APTT clot wave from analysis in ISTS 2017 at Berlin, World Congress in Hemophilia 2020, ISTS 2020, and he has organized hands-on workshop in coagulation techniques. This I can vouch because I have attended his workshop recently. I think you remember me. And it was very well organized, and because of that, we have been able to start the Hemophilia lab at Nagpur. As rightly said by Dr. Apte, that MD pathologists, they definitely fear for the hemophilia test, which I also had a fear, but that fear is gone because of you people and Dr. Apte organization. It was very well organized, and it was a great hospitality you have done over there. Thank you very much for that.
That's a compliment for us.
Thank you, sir. Please, over to you.
So, good morning, everyone. And thank you very much, Dr. Anju, for giving me this opportunity to be with all of you today. I feel fortunate enough that I'm working with Apte sir. yes, it has made me a different person in over a period of last 5 to 6 years, since I'm associated with Apte sir and particularly working in the field of hemophilia. One has to be thankful to God for these kind of services if we are able to extend it to it. Now, I will be speaking today on diagnostic hemostasis. But yes, I will not go into the laboratory techniques. I know most of you are clinical people, so I will not go into the technical details or the laboratory techniques, which I have already shared with Dr. Rathi. He was there with us for 4 days. So I'll just try to concentrate on the duties of a laboratory and what a clinician should expect from a laboratory report. So I'll stick to that only. Okay. So with this, so many times you'll be sending a report for prothrombin time or APDT. And if the report comes like this, PT test upon PT control, I feel it is an incomplete report and a clinician should insist on some more things. Or if the APDT comes as 104 against a control of 33, what is the interpretation of that? So one has to be more sure about what the report should contain. Or these two reports are from, I don't know whether it is clearly visible or not, but these are the two reports of factor assay on 2 different days on same patient. One value is 168%, the other value is 28%. So how is this difference? Whether it's the laboratory error or there is something else in this. So one has to be very clear. The lab has to be more specific in mentioning some additional things on the report. At the same time, the clinician should also request to the laboratory person, please give me some additional inputs. So what are those? Let us come to that. So I'll begin with the cell-based theory of coagulation, little bit of theoretical part, wherein upon breach in the continuity of the endothelial vessel wall, there is exposure of the tissue factor, which activates the factor 7, and there is a complex of tissue factor to 7A. And this actually, part of it goes for the activation of factor 9, and majority of the part of this complex activates the factor 10 to 10A. And this is called as the extrinsic kinase. And this is actually the initiation of the process of hemostasis. Now, this 10A goes to convert the prothrombin to thrombin, and little amount of thrombin is formed. And this thrombin itself acts as a boost for the amplification process. This thrombin goes and converts the factor 11 to 11A, and some of it goes to activate factor 8 as well by cleavage from the von Willebrand factor. And this 8A and 11A, this 11A again binds to factor 9 and converts some more factor 9 to 9A. Plus, there is some 9A which is available from the activated tissue factor 7A pathway. And this combination of factor 8A and factor 9A forms an intrinsic kinase complex, which converts the 10 to 10A. And this is in large amounts. So the intrinsic kinase which is formed is in large amounts. That again goes to convert prothrombin to thrombin with the help of factor 5. And this then there is large amounts of thrombin which is formed, and this thrombin then initiates the conversion of fibrinogen to fibrin and the stabilization of this fibrin clot with the help of factor 13. So this entire process happens on the surface of platelets. Once the platelets are activated, then everything happens with the help of the phospholipids on the surface of platelets. So this is the cell-based theory which actually happens inside the body, but this never happens in the laboratory. The laboratory again is still working on the old theory of coagulation cascade or waterfall theory, wherein 2 different pathways are being mentioned: the extrinsic pathway, which is related to the tissue factor and the factor 7, and the intrinsic pathway, which starts from factor 12 and ends up to activation of the factor 8A. So this is the still being done in the laboratories, and this is achieved by some combination of the reagents for the prothrombin time and the APDT reagents. So what happens actually? These are nothing but PT and APDT are nothing but the recalcification processes. Prothrombin time, it is nothing but the plasma clotting time in presence of tissue factor, calcium chloride, and phospholipids, which is called as calcium thromboplastin. In partial thromboplastin time, it's nothing but clotting times in absence of tissue factor. There is only presence of phospholipids and calcium chloride, and there is a presence of activators to that. And as Apte sir has already told you, factor assays are nothing but modified ways of doing the or extended ways of doing the either PT for factor 7, factor 10, and factor 5, or modified APDT for the 8, 9, 11, 12. So the prothrombin time reagent, what it contains is the thromboplastin or the tissue factor. This is nothing but it is derived from either humans like the human brain or human placenta, which is the most preferred source of thromboplastin for the simple reason of like versus like, but it's really tough to get it. So the rabbit brain thromboplastins are also available, which are also equally good. But the most important is the recombinant technology, which is being used right now, which is available, and it is more being utilized just for the reason that it gets very little variation between the batches and you get a stable ISI. ISI is nothing but an international sensitivity index, a standardization index, and it should be as close to 1 as possible. I'm not going to the details of the ISI. So with that, I'll come to one of the intricacies of prothrombin time if INR is not reported. So this is a patient who has, it's a middle-aged patient who undergoes surgery for the rheumatic heart disease, and post-surgery, he started on oral anticoagulation. So at the center where this surgery happens, PT after the starting of the oral anticoagulation is 28 seconds against the control of 11.2. The INR is 2.6, which is the target INR everyone expects for the oral anticoagulant therapy. Patient gets discharged with an advice that he has to repeat the prothrombin time at his local laboratory. Patient goes back home at the local lab, PT is measured, just PT value is given to the patient, which is 20 seconds, and the local physician feels that it is lesser than what it was at the referring center. So the dose is raised. The next week, the PT goes to 25, still less than the initial PT value. So again, the dose is raised, and the next week, patient's PT is 41 seconds, and the patient becomes unconscious. So again, the patient is referred back to the referring hospital, wherein his PT value is 90 seconds and the INR is 8.9. Now look at these intricacies. So the MNPT for the first value was 11.2, the ISI value was 1.05, the INR was 2.6. But if you look at the subsequent values at the local laboratory, the reagent which was used for the prothrombin time had an ISI value of 1.8. Okay, and all the INRs were in the range of 2.7. So the initial value of 20 seconds, the INR was very well within the range which the referring hospital has done. So there was no need for the increasing dosage. But since the INR value was not reported by the laboratory, it was misunderstood and misinterpreted, and the dosage was raised. So that indicates that the report should contain the ISI value as well as the INR value for that sample. So it makes this report a complete report. So every clinician should be insisting on the ISI value of the PT reagent which the lab is using, which should ideally be as close to 1 as possible, and the INR value for that result. Now, believe me, the reagents which are having an ISI value of as close to 1 are the most costliest as compared to the ISI value of 1.8 or 1.5. That's why the local labs, just for the purpose of cost constraints, they are using reagents which are inferior in the quality. But that's definitely going to hamper the patient status. Now, again, this is the coagulation cascade. Now, the intrinsic pathway, which is represented by the test of APDT, it deals with factor 8, 9, 11, 12. It starts from factor 12. It initiates the activation of factor 12 through surface activation. 12 activates the 11, 11 to 9, and 9 to 8. So APDT is actually dealing with the factor 8, 9, 11, 12. So what are the reagents which are used for the APDT? It's only nothing but phospholipids and the activators along with calcium chloride. So the sources of phospholipids are different. Some are natural and some are synthetic. Plus, there are some activators which are being used: silica, ellagic acid, psilite, and kaolin. Now, most of the labs are not using, or most of the manufacturers are also not using kaolin, that being a particulate activator. It interferes with the optical pathway in photo-optic analyzers. So most commonly used are silica and ellagic acid. And the sources of phospholipids, I won't go into the details. The sources, natural sources, are the soy-based, egg yolk, and the synthetic phospholipids are available, which again, as like PT reagent, has got minimal variation between the batches. Most important is nothing but the concentration of the phospholipids which is being used. So what are the targets of APDT? APDT should be representation for the intrinsic pathway. That is the deficiency for factor 8, 9, 11, 12. And as far as bleeding is concerned, 12 is removed. So it is 8, 9, and 11. It should also pick a common pathway factor deficiency, that is 2, 5, 10. It should be useful for the monitoring of heparin therapy and the lupus anticoag. So these are the main targets. So these targets for APDT itself are too wide and variable. So one has to be very sure for what purpose APDT is being advised. Even the lab has to be sure for what purpose the APDT is being advised, right? And it is used as an extended test for the factor assays as well. So this patient's report. Now this patient's report, it was 104 seconds against 31 seconds. But this was a post-plasma exchange samples, and all of us know that heparin is being used during the plasma exchange therapy. So there was a contamination of heparin during in these samples, which resulted in the prolongation of APDT. Now, just to keep you informed that there are situations, particularly in pediatric samples, most of the samples do have icteric plasma, or some of the patients do have a lipemic plasma, wherein these samples do interfere with the photo optics, and those can result in erroneous results. But with the help of newer coagulation analyzers, it has been studied that the interference of these hemolyzed or icteric and the lipemic plasmas are overcome with a wavelength of above 550 or 600. So most of the new analyzers do come with a wavelength of more than 600 nanometers, wherein if the patient's plasma is lipemic or if the patient plasma is icteric, and actually a hemolyzed plasma should not be used for testing, but if it is irreplaceable, then even the hemolyzed plasmas, the machine automatically shifts itself to a wavelength of more than 600, so that these interferences are removed and an actual result is being released. So this comes with the newer analyzers. So this is called as HIL interface. And one more additional thing I would like to keep you informed, that since most of you are being pediatricians, the reference ranges during the pediatric till the age of 6 months, that is till the liver is fully functioning, are altogetherly different from the adult reference ranges. So particularly for APDT, the reference ranges are quite high as compared to the adult APDT values. So the reference ranges can go up to 75 for the neonatal age group, or for the infantile age group up to 55 or 60 seconds. when adult APDT up to 35 to 40 seconds is considered as normal. So laboratory approach for a bleeding patient. When is the actual need for evaluation? That is, if the patient has a current episode of bleeding, or if there is any past history of bleeding, or if there is any family history of bleeding. Plus, during the preoperative screens, if the patient definitely has some positive family history or there is some medication history, and if you receive any abnormal clotting result from any other lab, right? In that case, there is definite need for the evaluation of these patients for the laboratory evaluations. History plays a major important role. Without history, there is no importance for any of the coagulation result. So history plays an important role. These are the details. I won't go into the details. Onset, site, everything plays a definite role. Family history should be there for knowing the consanguinity. And history of transfusions particularly, or the history of exposure to the factors actually plays a very major role. And umbilical stump bleeding, all of you know whether it is relevant to factor 13 deficiency or fibrinogen deficiency. For the evaluation of bleeding, there is a very good document which is freely available on the website of ISTH, that is the ISTH bleeding assessment tool for the calculation of bleeding score, wherein every bleeding symptom is categorized from 0 to 4 depending upon the requirement of the medical care for this. And a bleeding score is calculated. So a significant bleeding score for males is more than 3, for females it is more than 5, and for children it is more than 2. This has got its own limitations, but it helps you actually in assessing the severity of the bleeding, so that you yourself can justify advising for the laboratory evaluation. So the decision pathway, there is some abnormal bleeding history, plus there are some signs of bleeding on clinical examination, wherein you feel that this has to be a likely bleeding disorder, wherein the laboratory screening is recommended. So the laboratory approach will be, first will be the demonstration of the defect, second will be the identification of the defect, third will be assessment of severity, then consequential studies like carrier detection and the monitoring of treatment. So we'll come to one single each. So the demonstration of the defect, these are the screening tests which are being used to differentiate between the different bleeding disorders like the superficial bleedings like von Willebrand disease or platelet function defects, wherein CVC with platelet count and morphology plays an important role. Bleeding time actually helps you in getting the differentiation between deep-seated bleeding versus the superficial bleeds. Clot retraction nobody uses right now. Most important are the PT and APDT to differentiate between extrinsic defect versus the intrinsic defect. Some of the labs may use thrombin time and fibrinogen assay as well. And factor 13 screen is a specific test wherein you get all the PT, APDT, CVC normal with only deficiency for the factor 13, since it is not involved in the formation of the clot. So this initial evaluation of the hemophilia patient, since hemophilia deals with factor 8, 9 and 11 deficiencies, it is particularly dealing with the APDT or the intrinsic pathway. You get a normal PT result and you get a prolonged APDT result. So what a lab has to perform is, if you get an abnormal bleeding history with a prolonged APDT, every lab has to do a correction study. Correction study means you have to correct the patient plasma, that is 50% patient plasma and 50% pool normal plasma. Now this pool normal plasma is nothing but a pool from 20 healthy volunteers. Minimum number mentioned is 20. 20 healthy volunteers. You have to collect the sample and pool the plasma, saturated plasma of these volunteers, so that it contains all the factors in a proper or a normal range, ideally 100%. So you are mixing the patient plasma with the pool normal plasma 50-50, so that you are supplying the missing factor to the patient plasma and you check whether the APDT is improved or not. If it is improved, it indicates that it has a factor deficiency. If it doesn't improve, then it is indicating towards the presence of an inhibitor. So this, say suppose patient's APDT is 80, it comes down to 36. There is probable, I think it's not visible. It is probable factor deficiency, most likely 8, 9, 11. And it can be, if PT is also prolonged, then it can be common factor pathway deficiency as well. Now, if PT and if the APDT is still prolonged, you suspect development of an inhibitor. Now, the subsequent test will be to do correction studies with factor 8 deficient plasma and factor 9 deficient plasma. So these either are available commercially or you can harvest the sample from a known hemophilic patient. So you can get the correction with factor 8 deficient plasma. If it is correcting, it shows presence of factor 9 or 11 deficiency. If it doesn't correct, then it indicates factor 8 deficiency. The same thing with factor 9 deficient plasma. If there is no correction, there is factor 9 deficiency. If there is correction, 8 or 11 deficiency. So with this correction studies, you can actually categorize provisionally which factor deficiency is there in the patient. And subsequently, what you need to do is to do the factor assay. Now, factor assay, I'm not going into the details of this factor 8 assay, what is being done in the laboratory, but it is nothing but a 3-point dilution APDT. Patient sample is diluted in 1, 10, 20, 40 dilutions. And then what is nothing being done is factor 8 assay. So this is the one-stage clot-based assay. The other way of doing it is a chromogenic assay, which has got its own importance in specific conditions. Once the patient is labeled, once the patient is diagnosed, then the patient starts his therapies. And the most important complication of treatment of hemophilia is nothing but development of inhibitors. Okay, so the inhibitor screen has to be performed. And the frequency of inhibitor screen is whenever there is clinical suspicion. In almost all cases of hemophilics wherein the patient undergoes a surgery, so pre-surgical is definitely an indication for inhibitor screen. And if there is any inadequate response to the dosage of the clotting factor concentrates and follow-up of inhibitor positive patients, these are the indications for doing the inhibitor screen. So what is being done in the inhibitor screen? Again, you do the 50-50 mix. If there is correction, then it is incubated at 37 degrees centigrade for 2 hours, because most of the factor 8 inhibitors are time dependent. This is not required for factor 9 inhibitors because factor 9 inhibitors are immediate acting inhibitors. So this incubation is not required for hemophilia B, but this is required for hemophilia A since these factor inhibitors are time dependent and act at 2 hours at 37 degrees centigrade. So this is done in the laboratory, fresh mix versus incubated mix. And if the difference between the fresh mix versus the incubated mix is more than 6 or 7 seconds, then it is considered as positive inhibitor. I'm not going to the technical details of that. Once you detect that there is the patient is having inhibitors, then what you have to do is to quantify the inhibitors, and that quantification is called as the Bethesda units. This is again nothing but inhibitor screen, which is done in dilutions. Okay, I'm not still going into the details. There are 2 ways of doing the Bethesda assay. One is the classical Bethesda assay, which is very well can be utilized for high titer inhibitors. But there is a chance that low titer inhibitors can be missed by the classical Bethesda assay. To improve the sensitivity, a Nijmegen modification has been done, wherein some minor changes has been done in this procedure, which improves the sensitivity of this test, and it can pick up the low titer inhibitors as well. So the factors affecting the clot-based assays are procedures for the sample collection, the APDT reagents which you are using, the source and concentration of the factor, the phospholipids, the activators which are being used. Those activators play an important role. How I will just see it. The calibration process, calibration used, assay design. But what is most important is the type of the CFC which is being used. Type
and the timing of CFC which is being used, that plays a major role for one-stage clot-based assays. We'll see a simple example. Now, I have showed this report to you. On one day, this patient had 165% factor rate, and after 4 to 5 days, this patient had 28% factor rate levels. How come this can happen? But this was nothing but the first sample was post-infusion 30-minute sample. So infusion was given at a dose of, so the expected recovery was 150%. So we got a 165% value. So this was post-infusion 30-minute sample. The next sample was post-infusion 24-hour sample, wherein according to the pharmacokinetics of this CFC, the expected levels were somewhere around 30%. So this was a patient who underwent surgery recently, and we had to monitor the factor levels. So this note has to be mentioned on the report so that you know exactly what is the status or the timing of CFC which is being used on this patient. So these footnotes are of immense importance while releasing a coagulation report. Okay, so that has to be taken into consideration by the issuing laboratory as well as the clinician who is interpreting this report. So these are the different available factors in the market. I think the names are not so clear, but these many, and all of you know how many factors are available. Some are plasma derived, some are recombinant, some are full length. So these are the types of CFCs which are available in the market: plasma derived and the recombinant factors. Some are full length, some are modified. Dr. Anju has already told you about the pegylation technique. Some are B domain dilated, some are B domain truncated, and some are recombinant Fc fusion protein. So these all the modifications, these are nothing but extended half-life products. These are nothing but extended half-life products. And for the purpose of getting this extension of the half-life, there is some modification which has been done in the basic molecule. Actually, this plays an important role as far as the monitoring of the therapy is concerned, and whatever the recovery of the factor assays you get from the laboratory. So these play an important role. So every modification of this extended half-life has an impact on the APDT value. And it is again related to the same things, that the source of phospholipids, the activators which are being used. Every activator actually interacts with this modified product differently, thereby giving you a different result, because all the factor assays are nothing but extended APDTs or modified APDTs. So these activators play an important role. So one has to be very well aware of the impact of this modification on APDT reagent, and the APDT reagent which is being used in his or her own laboratory as well. And these are the APDT reagents which are available, which are nothing but the combinations of these different reagents. So these many numbers of APDT, this is again representative only. There are so many manufacturers available in the country, and there are so many manufacturers providing the APDT reagents. So it makes a mixture of a variety of clotting factor concentrates with a variety of APDT reagents. That is the spoil sport, unless and until you know what you are doing. Okay, so that plays an important role. So there are some recommendations. So for plasma derived CFCs, no specific APDT reagent is recommended. You can use any reagent, because these plasma derived products actually mimic what is happening inside the body. But the other one is the full length recombinant CFCs. Again, no specific APDT reagent is required. But for this Fc fusion, then pegylation, then this is single chain, NHGP, the B94. Now, these are the APDT reagents which are available this is still a standard list of reagents. Now you can see Synthesil, except for the single chain, it can estimate the factor 8 level correctly. Okay, so similarly, it is being mentioned for all the APTT reagents available in the market. What is the most important is recombinant single chain factor 8. Most of the routinely reagent, whatever the available are reagents are there, it is underestimating the factor level. So what is recommended is chromogenic factor 8 levels only for this single chain. Otherwise, you can go through this and you know what exactly it is happening. Similarly, the same thing happens for hemophilia B patients, the factor 9 levels also. Dr. Anju has showed you there was one patient, one surgery happened in AFMC Pune. So this patient was posted for surgery and the patient received Refixia. So initially, the day prior to surgery, 500 units were given and the sample was sent for the recovery assay. And the expected levels were 20 to 30%. The lab got a value of 200%. Okay, but still the hospital went ahead, infused 4,000 units in the morning pre-op, and the sample was sent for the recovery assay, and the expected recovery was 100%. The lab there got a value of 800%. So then the clinician was just horrified. So then they send the sample to lab B, that is our lab. So we use two different reagents. One is silica-based reagent, the other one is ellagic acid-based reagent. So we did the factor 9 assay with both the reagents. So the silica-based assay was 29%. And we did the ellagic acid-based, that was 93%. So this Refixia or these no-knowledge people, they have published their own document that the recovery assay should be established with specific reagents, preferably ellagic acid base, that too one specific reagent, that is Synthofax, which was available with us, and that gave us a perfect value of around 100%. Even the ellagic acid based reagent which was available was almost 1/3 the value which was expected. And this was the kaolin based reagent, it gave so much of erroneous value. So the lab has to know which product has been infused to the patient, and the clinician has to know that after using this product, which reagents to be used for the recovery assay and how it is to be done. So hemostasis is a team activity. It's a group activity. So Apte sir always says that there is nothing like a clinical hematologist or a laboratory hematologist as far as the hemostasis is concerned. Both should know, each and everyone, how it is being done and where it is to be done. Okay, so there are some specific reagents which have been mentioned. So Synthofax is specifically mentioned for this N9GP. So coming back to factor 8 in hemostasis, we all know it is the inactive form is bound to 1 Willebrand factor, and once thrombin is generated, thrombin cleaves this binding and activates the factor 8 to factor 8A, and it actually binds on one side to 9A, and this complex then binds to or activates the factor 10 to 10A. Right. So factor 8 plays a major role in the conversion of 10 to 10A with the help of factor 9 or the factor 9A. Now imagine in patients of hemophilia, this factor 8 is missing. So there is no activation of factor 10 to 10A. Thereby, there is no formation of the clot. So imicizumab is a bispecific antibody actually, which is binding to on one side to factor 9A and on the other side to factor 10. Thereby, it is replacing the factor 8 levels, and this actually helps to convert 10 to 10A, thereby completing the coagulation pathway. So this is a non-factor therapy which is being recently used, and this is used for patients with inhibitors or patients without inhibitors as well. So if the patient is on imicizumab, remember this imicizumab is replacing factor 8. So all the clot-based assays will come down to normal. So PT will always be normal. It is there. It is normal in hemophilics, but in patients with inhibitors or without inhibitors, the APTT is coming down to normal, or it can be shortened as well if the patient is on imsuzumab. We have seen that Apte sir has already told you that the dosing for imsuzumab is once in a month. So we have seen there are some patients, even after 1.5 to 2 months, the patient's APTT doesn't cross 30 seconds. Okay. And since most of the clot-based factor assays are nothing but extended APTTs, most of the times the factor assays do come normal or do come raised, even if the patient has not received any factor. And once you give imsuzumab, there is no need for the factor replacement therapy. But all the clot-based assays, you will get raised factor VIII levels. Ideally, if the patient is on imsuzumab, there is no need for factor VIII monitoring, even in patients of on inhibitors, with inhibitors or without inhibitors as well. But if at all, the patients with inhibitors have to be monitored for their inhibitor status, then in that case, clot-based factor VIII assay-based Bethesda is not to be used. Like the classical or the Nijmegen Bethesda assay is not to be used, because factor VIII will be raised and you get a falsely negative result. What is to be used is nothing but chromogenic Bethesda assay, wherein the technique which is used for chromogenic assay is altogether different. It is nothing but using of factor IX, the thrombin, and the factor X. Okay, that's why for patients on imsuzumab, only chromogenic Bethesda assays are recommended if the patient has to be monitored for the inhibitor status. For patients without inhibitors, you can just monitor based on the PT and APTT value. So what are the challenges a lab faces? The most important challenge what a lab faces is the workload. So most of the labs say that we receive hardly 2 or 3 APTT samples, or for which we are not able to consume the reagents, and the reagent stability, the open vial stability, the lab faces too many challenges in maintaining this reagent stability. Then comes the sample integrity, because majority of the times the sample is collected at some place, the sample is transported to the other lab, the transport conditions are not maintained. I have not gone into the details of the pre-analytical issues, but that play a major role. Then to make the pool normal plasma in-house, I told you, you need 20 healthy volunteers. Now, believe me, it's really tough to get 20 healthy volunteers on a frequent basis, at least once in 3 months, once in 4 months. It's really difficult to get 20 healthy volunteers. It's not so easy job. But a coagulation lab, you need pool normal plasma. Without that, you cannot run a coagulation lab. And the most important is the awareness. Just the few things I told you about this. So the most important solution on sample load will be sample pooling. Apte sir also mentions in most of his talks that in smaller centers, you need to pool the samples. Every lab should not be doing PT and APTT. Rather, you find one center wherein the other labs will be sending their own samples, so that one center gets a good sample load, and the utility of or the issue of reagent consumption is solved. I know it's not so easy task, or it's not so easy thing to be done in private practice, but that is the way to go ahead. Unless and until you have your own patient pool, it's really difficult to sustain these kind of things. Better sample transport, then a specific pool of volunteers. You need to identify your own pool so that you can request them. You can only request them. There is nothing way to go ahead. And training. There is nothing beyond training. Okay. So with that, I would like to thank for this patient listening, and I'm happy to receive the questions.
Thank you, Dr. Rajesh, for that lucid talk. You very well elaborated on the importance of pre-analytical variables, actually. And actually, the detailed history in pre-analytical variable is the heart of coagulation lab. If you don't start from there, we are not able to get the right answer.
Exactly.
So I think I will just like to add, if you have an abnormal result, please do call your pathologist and together you can get the answer.
Exactly. Yeah.
Because at times it is the reagent, at times it is the analyzer, at times it is the combination, or at times it is the drug in the patient. Something is haywire and probably that's why the analyzer is telling you that. Any questions from the audience?
That's why we always say there is nothing like a clinical hematologist or a laboratory hematologist as far as hemostasis is concerned. Entire hematology person.
Sir, only your points to how to go about collection, because there are a lot of issues like whether it should be empty stomach and how long the drug should be off before taking a sample. What are the medication that should be avoided before taking a sample, and how it is to be drawn, because these are the concern, because we pediatrician collect blood drop by drop. And there the error comes because you're not shaking the tube, and how many times you should shake the tube. Does it activate? The contact activation happens. And these are the various issues that I think pediatricians as clinicians, we still are not aware.
So that's an important issue as far as the pediatric practice is concerned and the neonatal samples are concerned. I know most of the vacuotenus. Now I would recommend you to use the vacuotenus. Even majority of the centers are not using vacuotenus and the vacuotenus collection. Most of the centers are doing the syringe collections and then transferring the samples to the containers, what you can say. As far as neonatal samples are concerned, this vacuotenus practice is really, really difficult. Most of the vacuotenus do come with a volume of minimum 2 ml. And drawing a 2 ml sample from a neonate is really a difficult job. But there are some companies, I will take the names also, the BD and the Grainer. Both these companies have come up with 1 ml microtenus. They call it as microtenus, but those are not vacuotenus. Definitely those are not vacuotenus. So for that purpose, rather than collecting drop by drop, you can collect by syringe, but without giving too much of negative pressure. The negative pressure should be progressive, or the minimal negative pressure should be applied, and the blood should be freely flowing, and it should be transferred to the anticoagulant as early as possible. And then the shaking part, whether it's an adult collection or whether it's a pediatric collection, the tube has to be gently inverted 5 to 6 times, gently inverted completely 5 to 6 times, so that the entire anticoagulant is mixed with the blood and there is no vigorous shaking that can activate the surface, the contact activation, or that can lead to hemolysis as well, or that can activate the platelets as well, vigorous shaking, and that can lead to erroneous result. So gentle inversion, complete inversion, 5 to 6 times for the cited samples. And once it is completely mixed, then it has to be transferred to the laboratory as early as possible. And we recommend that the plasma should be separated within 30 to 40 minutes of collection. Okay. Now, again, going further beyond to that, most of the coagulation tests should be performed within 4 hours of the collection of the sample. Plasma should be separated within 30 to 40 minutes, and the test which is to be performed within 4 hours. PT is relatively stable. So PT can be performed up to 24 hours at room temperature, only PT. Okay, not any other test. All other tests in coagulation to be processed within 4 hours. And if the test cannot be performed within 4 hours, the plasma has to be immediately stored at -20 at least. -20. It should be freezed at -20. If available, -80 will be a good option. And once the frozen sample has to be processed, it has to be thawed at 37 degrees centigrade, immediately transferring from -80 to 37 degrees centigrade without keeping it at room temperature. If it is kept even for 2 to 3 minutes at room temperature, there is formation of the cryoprecipitate, wherein most of the factor 8, the fibrinogen will be consumed, and what is left behind will be a factor 8 deficient plasma. So that all again your results will be erroneous. So immediately it has to be thawed and transferred to 37 degrees centigrade water bath, and then it has to be thawed.
I'll just make some additions to what Rajesh said. First and foremost, in our institute, we have 2 nurses collect all neonatal / infantile samples. Once patient crosses 1 year, it becomes much easier to collect the sample. Second thing, it's a very strict instruction not to do femoral puncture to collect blood in a neonate or an infant, because that's a disaster. Especially if you are having it is safer to use the radial artery puncture to collect blood. Fourth thing we must keep in mind, the infantile neonatal normal ranges are different. A 10-day-old child, 70 seconds APTT is normal.
No.
Don't chase it. Don't chase it. It takes around 6 months for the child to grow, for the APTT especially to come in the normal range. Because what ranges we are talking in the report are all adult ranges. We do not have separate adult versus pediatric versus infantile ranges in our reports. That is the ideal way, but no lab in the world is doing that. Then, other thing I would always say, if you have a real neonate, below days 28, and you are suspecting bleeding disorder, it is most likely non-A, non-B bleeding disorder. Hemophilia A and B do not present, it can present, but generally they will go down. And if you have any infantile neonatal very small child, immediately ask a family history. If there is a patient in the family, you evaluate him, most early the child will have same diagnosis. We do that. We do that. When very small children, they are referred, when they call us, I say, if there is any involved person, get that person also. Because generally hemophilia A in the family, the child will also be hemophilia A.
So thank you for that comment. And sir, if you can elaborate on shipment, how to take care of that. If you are a reference center and you're receiving sample from outside the Pune, so how do you kind of give them instructions how the sample PPP should be separated and how the freezing needs to be taken care before it reaches you? Because that is entirely a different challenge. When we talk about, having one center who's receiving sample from different centers. In AIIMS Delhi, we used to have a policy that we'll collect the sample in AIIMS Delhi so that, we kind of take care of these issues. But that's not a possibility at every level. So how do we take care of that issue?
Yeah, this we have been doing with Dr. Anju for a we have done it frequently. So when I talked about the sample pooling, I meant within the city.
Yes, that is.
So within the city, yes, you can transfer the sample, you can transport the sample as early as possible within 30 minutes, it should be okay. And if it is going to take time, even to within the city as well, then there has to be a good quality centrifuge at the collection center itself. Okay. And there are centrifugation techniques. So there are centrifugation protocols. So one should be knowing the radius of the centrifuge which is being used, and the ideal way of going ahead with will be somewhere around 1500 to 2000 G or 3000 to 3500 RPM for 15 minutes for the centrifugation of the sample. So centrifuge plasma should be separated there itself, and if it is going to reach within 1 hour or okay, then it can be transported at room temperature, not on ice. Okay, not on ice, because there can be cold activation of factor 7, or the platelets can get activated even at the on ice. So to avoid that, it should be transported at room temperature, right? So this is within the city. Once the sample reaches the lab, then it's the lab's road. If they are doing it with, immediately, they can do it. Otherwise, it can be frozen at -80. Now, if the sample has to be shipped to another center, like across the cities, then you have to centrifuge, as I mentioned. Then you have to transport the sample on dry ice. So dry ice has got a temperature of -80. It is dry ice, specifically the dry ice. Now, this happened with one of our camps, wherein we had recommended the lab or the collection center that we need dry ice. He said, okay, it's nothing, we can get it. And when the team reached, they took us to a routine.
I can completely understand. So that's why I brought up that point. You know, when we
So-
mean dry ice, we mean dry ice.
So बर्फाच्या फॅक्टरी समोर घेऊन गेले ते. आपण इथं आता आईस घेणार आहोत म्हणे. So it's a dry ice, a specific thing, and it's a costlier affair as well. It's cost somewhere around 1,000 or 2,000 rupees per kg. Okay, so dry ice wherein the temperature goes to -80. So immediately the centrifuge aliquots have to be transferred to -80, and then that can be shipped. So the dry ice can be in a thermocol container, wherein there will be little bit of loss of heat, because we have seen samples received from Nagpur to our center. When we check the temperature in dry ice, it was -80 only in the thermocol container. So it is very well stable for at least 3 to 4 days, right? So the temperature won't vary. And even if the temperature goes above till -40, -50, still it's okay, because still -20 there won't be any issues. So that has to be shipped, particularly in dry ice, to the processing center. Right.
Any other question? I think if there are no more questions, we conclude the session. Thank you for that lucid talk, sir.
Thank you very much.
Thank you, Dr. Rajesh. Thank you, chairpersons. I request Dr. Dange sir to kindly felicitate our speaker. And also our chairpersons, Dr. Juneja and Dr. Rathi sir. So with this, we move on to the next session, Surgery in Hemophilia by Dr. Shashikant Apte. And to chair this session, I invite Dr. Nishad Dhakade and Dr. Amit Nemade.
Very good afternoon, everyone. So we already had a good introduction of Dr. Apte sir, who is an eminent faculty. Without much ado, I would directly hand over the mic to Apte sir for this session. Hemophilia is a team approach. The main lead is the medical fraternity, but sometimes due to unexpected events like hematomas and other things and the natural progression of the disease of the joint, they can land up into different problems, including muscle hematomas, joint degeneration, other systemic involvement. So role of a surgeon sometimes is important here to be a life-saving or a limb-saving event. Over to you, sir. Thank you.
Thank you, sir, for kind words. So I'll come to the part of surgery in PWH, and it is one of the most difficult areas for the center to do it, because every surgeon is always worried about the bleed. And every surgeon is always going to call a bleed a non-surgical bleed. And it is true, majority of the times the bleed is non-surgical. But when we have a congenital bleeding disorder or an acquired bleeding disorder, we have to be more careful and more organized. So basically, PWH surgery is a teamwork. And let me again say that it has evolved over the last 24 years. Most importantly for hemophilic, as Dr. Pofre asked, is the fundraising. We need a huge fundraising and a lot of charity done by our colleagues. And luckily, I've been very fortunate that none of us, we charge our personal charges for any hemophilia work. So there are questions before the scientific community. What is the optimal hemostasis required during a surgical challenge? Nobody knows this answer, even in normal individuals. Why some mild PWH will not bleed during surgical procedure and may escape undiagnosed? Again, we do not know. And how the diverse replacement policies work equally effectively? These three questions are still unanswered in 2022, and these have been haunting the hemostasis community over the last 50 years. The first data came up in international journal was in Hemophilia Journal 1994 by Kevin Ricard, and he showed these kind of guidelines for the replacement policies. But these replacement policies roughly use 1000 IU per kg during the surgical procedure. But this was not at all an evidence-based protocol, but it became a sacrosanct word in world of hemophilia, because this was the first published data in the international journal. I'm purposely using the word international. What is the hemostatic levels for the different hemostatic challenges? The question was unanswered. Until the guidelines published by the World Federation and WHO, this was taken as the gospel truth. But this paper, which I was also one of the authors, was published in 1993 November issue from CMC Vellore. Dr. Maman, Dr. Alok, Vikas, and Dr. Khanduri, Dr. Denison, and myself. This was the data on nearly 162 surgical procedures over a period of 3-4 years, using plasma and various products, and much lower dose was used. No reference was shown to this article in Kevin Ricard's paper. So when we have indications for surgery, we have to keep in mind that the surgical indication may be related to hemophilia or may not be related to hemophilia. And more than 70% surgical intervention, especially orthopedic, are related to hemophilia. So there are certain principles to be carried out, and the first principle is that you have to maintain certain level of missing factor till the wound healing is over to avoid secondary hemorrhage. And what is that level is the key question haunting the world. So surgery can be elective surgery, emergency surgery, it can be major and minor surgery. See, elective surgery, we always have time. Like any joint replacement is always an elective surgery. So we have time to organize the work, organize the thing. But when somebody comes with IC bleed, like we had a patient 2-3 days back, the center really has to be geared up to tackle these emergencies. Because in an IC bleed, though the child that time was stable, looking at the CT scan, he would have coned at any time. So the prerequisite, the first more important prerequisite is that it should be performed in a center that includes timely access to laboratory monitoring of the factor activity. While 6 years I've been vice president, we were getting World Federation product. We used to get a lot of requests that we need extra factor for surgery. So I had to refuse, and we ultimately came out with the guidelines that unless these things are prerequisites are met, we will not support, because it's a stupid thing to believe that only factor is required for doing a surgery in hemophilia. Center must have accessibility to factor, including bypassing factor. But suddenly intra-op, we have seen patients developing inhibitor, especially if they have not been exposed to factors before in their life. There has to be the complete team trying to pull out the surgical evaluation. We get a request that we are going to do TCAR. We are one of the best surgeons available in the country to do TCAR. That's not the only prerequisite. You have to have a lab, you have to have a hematology team, you have to have nurses to assess those things. Surgical expertise is very important, and surgical cooperation is very important. Like, especially when you know that you are going to request to write off the charges, some surgeons will not agree. Some surgeons will very willingly do. So we have seen certain people saying that, and we had to raise funds to, but these have been less often, more often that the fees get written off, and that is the only way, because majority of the patients can't afford anything. And most important thing is to convince the anesthetist. I remember when we posted first patient for surgery 24 years back, the previous day anesthetist came and wrote, surgery cancelled as EPDT is prolonged. I had to say, ma'am, when the patient hits the OT, the EPDT will be normal, factor level will be normal. It was not their mistake because they had never seen a hemophilia surgery being done. So these are the prerequisites that the center has to able to do before you do the surgery. And let me honestly tell you, venous access is very, very crucial because we have to monitor the levels, we have to collect the samples. So everybody gets a PICC line, whatever surgery, any major surgery. For dental extraction and all, we will not put a PICC line. Tomorrow we have a patient who is undergoing colostomy closure. So already today the resident would have put a PICC line and tomorrow he will go to the OT because he will require monitoring for next 2 weeks. Because the wound healing will take for 2 weeks. He had a pseudotumor involving descending colon. So we had to do the colostomy, remove the pseudotumor. The colostomy will be closed tomorrow. So, but he had a surgery 3 months back and now he will go for correction. This is a major surgery. It cannot be done just because you have got an excellent general surgeon or an excellent oncosurgeon doing this surgery. So when we do the preoperative evaluation, we always do the baseline coagulation workup again. Make sure that if the patient is not on factor, that if it is truly, generally it has never happened, but we don't want to deviate from this protocol. We always do inhibitor screen and mini Bethesda assay before any major surgery. This person has now exposure days to 60. He has undergone a major surgery 3 months back. That time his mini Bethesda was negative, inhibitor screen was negative, but he received extensive exposure to factor VIII. We will get the mini Bethesda report by tomorrow morning. The surgery is posted at 2 o'clock in the afternoon. Generally, we prefer to do surgery at 8 a.m. in the morning. I'll tell you the reason and I'll show you the algorithm. So laboratory services with Rajesh and his team, we always have 24/7 backup. Even late in the night, suppose suddenly I ask for an inhibitor, one of the senior technicians will come and will get the inhibitor report. All of us, like around 6 months back, suddenly there was the issue. We have 2 major centers, Nagar Road Sahyadri and Deccan Sahyadri. So Deccan Sahyadri, we do all elective major surgery, but emergency happened. Factor VIII assay machine, there was calibration had gone haywire. So we did manual, myself and my registrar, we did a manual assay. And we documented that the level was 86%. This happened at around 10 o'clock in the night. So everybody keeps doing manual assays at least once a week, even in the lab, because machines can go wrong anytime. We make sure that we have proper reagents, machines are very well calibrated, and always there is a backup of manual assays. So when we replace factor, there are certain principles. When we give 1 unit per kg, the rise will be by 2%, 2 units per DL or 2%. So suppose I have a severe hemophiliac and I want to hit level of 100%, I would give 50 IU per kg of factor VIII. Whereas for the factor IX, the increment is by 1%. So if I have to hit 100%, I'll have to give 100 IU per kg for factor IX. And there are factor replacement, we use bolus intermittent policy, and obviously we use the low dose protocol. This was the CFC patterns now published. And one major mistake was done. In 2012 guidelines, the word used was resource constraint setting. And we had a huge argument, and that resource constraint has been replaced by low dose protocol and a high dose protocol. Why Germany cannot use a low dose protocol? They're not, because once you put a level of resource constraint, it became unethical in Germany or unethical in a developed world to use that protocol. So in 2020 guidelines, that resource constraint has been replaced by low dose practice pattern. And you can see the difference in this. So CFC for hemophilia, for any major surgery, it will, for hemophilia A, would come to around 300 IU per kg. So suppose the person is 50 kilos and is undergoing something like, say, appendectomy and doesn't have inhibitor, I would be very happy to have 15,000 units with me and keep a 5,000 units for extra backup. And we always tell surgeons, please do not blame surgery, hemophilia for a bleeding. We did a huge pseudotumor surgery a couple of years back. Night he started bleeding. surgical reaction was this is hemophilic bleed, but we documented that the factor level was 74%. At 12 o'clock in the night, we could do the factor assay, and I forced them with that report to reopen the person. There was a slip ligature. They just ligated the bleeder and bleeding stopped. Other thing, in a surgical setting, we always, if possible, if required, we leave the drain. Suppose the drain is bleeding and surgical skin site is not bleeding, it is not a hemophilic bleed. Because if it is a hemophilic bleed, even the skin should bleed. If skin is clean and there is a drain, obviously there is a bleed inside or there is a bleeder inside. So they need a opening up of that patient. The same thing. So generally, this would be the replacement policy if you are using higher dose or a lower dose, and both the comparative dosages I have shown here. Perioperatively, we keep in touch with the surgical theatre. Every 1 hour, the call goes from senior registrar or a consultant or a senior nurse. We have a nurse coordinator who plays a very important role, finding out what has been the bleed, how the surgery is proceeding. And sometimes, especially with pseudotumor surgery, intra-op, we do hemogram, PT-PTT, fibrinogen, and factor VIII assay again. Because pseudotumor surgeries are known to go into a transient DIC-like picture. So you may need a replacement of fibrinogen. And unless you document PT-PTT and fibrinogen, you will miss DIC intra-op. So this is the sequence. On the day of surgery, everything is ready. Lines have been put. OT is confirmed. 6:30 a.m., the selected dose will be given. 7 a.m., the sample collection will happen. By 7:45, we'll have the factor assay. And with the factor assay being corroborated with the dose that we are given, the patient will be shifted. We will inform anesthetist, we will inform everybody, including lab, that the patient is going for surgery. And we have created a group on the WhatsApp, and everybody receives the message on WhatsApp. We instruct the OT sister in charge that now you are responsible for communicating with us, because we can't go inside every now and then. So sister in charge in the OT is generally monitoring the surgical proceedings inside the OT. Once everything is done, if required, we do the factor VIII assay, as I said, if there is a prolonged surgery, but now we have created a protocol for every pseudotumor. We will use this intra-op measurement of the coagulation proteins and replace accordingly. And generally, we do another factor assay at 6 p.m. in the evening to decide what is the half-life of that product in that given patient. Because it's a biological product, so half-life is going to change from individual to individual. Basically, we'll do this to save the product. Otherwise, suppose we are given 3,000 units in the morning, the textbook algorithm will say, give 1,500 units in the night. But we have seen that many times we are getting away with a lesser dose. When there is a post-operative bleeding, first thing we, as I said, we look at the surgical site bleeding and the drain bleed. And we look at the factor recovery. If the factor recovery is there, it is not a hemophilic bleed, we tell the person to open, and we always again check the inhibitor. Because there could be inhibitor development during the perioperative period. But if these two things are ruled out, the surgeons are on backup and they will open up the person again. This is our own data between July 98 to October 2022, that we have totally done 621 surgeries, 285 have been major surgeries. Of that, 48 have been emergency surgeries. November data is not there, so last 4 surgeries are not included here. And we have done 27 surgeries for other bleeding disorders, non-hemophilia A or non-hemophilia B. Because we are monitoring all the factors in our center, even factor 11. Another thing, factor 12 is not a bleeding disorder, factor 12 deficiency. You will have prolonged APTT. And if it is, history is not suggestive, if it is factor 12 deficiency, we do nothing. We tell the surgical team and anesthesia team, please operate like any other person. Again, that was it took us some convincing to tell them it is factor 12, APTT is 100 seconds. Everybody will get scared. APTT 100 seconds, how can I put my knife on it? Nothing happens. It's not a bleeding disorder. Factor 12 is called as a Hegman's factor. And Joseph Hegman died of recurrent pulmonary emboli. Factor 12 we today know is a thrombotic disorder with prolonged rapidity. So with extended product, we got excellent. There is a typo mistake that should be October 22. Extended product becoming available really pushed up our surgical work. And these are the types of surgeries that we have done. Bilateral TKR is our policy. Generally, the orthopedic surgeons would do even in normal individual one joint after third day or fourth day. But now a lot of people are doing simultaneous bilateral TKRs. Right from day one, our first bilateral TKR happened in 2006. We did it as a combined surgery because we wanted to save the factor. Just for the saving of the factor. Because when the level is 80%, you can do one joint, you can do two joints. But we never clubbed an infective surgery with a non-infective surgery. Like we had one pseudotumor which was infected, he was also going to require THR. So we allowed the pseudotumor wound, everything to heal out. And after 6 months, we did THR. Because we don't want that processes to get infected. This is our published data on first 24 cases of bilateral TKRs in blood. And we maintained 50 IU per kg. The level maintained was 108 at the median with the range of 86 to 126 IU per DL during the surgical time. And total elected use was 510 to 640 IU per kg over 14 days, which is very, very low. In the literature, the high dose protocol would have used somewhere around 1500 IU per kg over 14 days. So it's a great saving, and low dose is equally effective hemostatically in these patients. So bilateral TKR definitely brings down the cost and becomes furthermore cost effective. This issue is emerging, and we are going to see issues because hemophilics are living longer. The care becoming available in the country, there are people crossing age of 60, age of 40. I'll show you the data in next 2 slides. And there is an increased life expectancy in PWH. And age-related issues the center has to tackle. Malignancy surgeries, obesity surgeries, renal surgeries, cardiothoracic surgeries, cardiovascular surgeries, cardiovascular bypasses are becoming more issues in the PWH, and comorbidities are on rise. This is the slide of 2012 from the NHR data when Dr. Cecil Ross was the Vice President Medical. That time, hardly 30% of the people, not 30, 20% of the people crossed the age group of 30. So you can see above age of 50, the population in the database was only 4%. In 10 years, with factor support becoming available at the state level, this is the data on 22,000 patients. Now 12 plus 16, 28 plus 9, 37% people are above age of 40. And you are going to see trouble in them. But we have seen a hemophilia at age of 32 with severe myocardial infarct. So coronary artery disease becomes a unique situation in hemophilia. Because post-procedure, whatever you do, you have to put them on antiplatelets. The current guidelines say that once you put an intervention and you're putting them on antiplatelets, you have to give lifelong prophylaxis, maintaining level at least 20%. To maintain level at 20% for a 80 kg hemophilic, you will need 2 lakh units of factor per year. It's huge. It has been shown generally the mortality of PWH with myocardial infarct is less because the thrombin generation is less. The thrombin burst is less. But that also taught us that severe hemophilia does not protect you from vascular disorder or ischemic heart disease. We have seen strokes, arterial strokes. We have luckily not seen a venous stroke so far. Because managing a venous stroke in a hemophilia will be more tricky because you are going to anticoagulate with one of the drugs like heparin or warfarin. But all our major surgeries, especially TKR, THR, we give low-dose LMWH prophylaxis because we are maintaining levels above 50%. This is a controversy. Some of the people say you should not give, but I firmly believe if you take a principle that a hemophilic should be operated like any other normal individual. If a normal individual is going to get LMWH prophylaxis, during TKR those 14 days or mobilization is done, I would give my hemophilic LMWH. And we have not had any bleeding complications with LMWH. So when we are considering hemophilic for coronary artery intervention, we have to really map the bleeding phenotype. Factor VIII level less than 1%, the bleeding phenotype can be very diverse, very, very diverse. One fellow may have 2 ABR, other fellow may have 50 ABR, other fellow may have had more than 200 exposures to factors. Some severe hemophilics, even at the age of 50, were doing well and would have hardly received any factor. So bleeding phenotype is very important, and we document the bleeding phenotype according to the phenotype markers. Duration of planned therapy is important, but if you are going to put a stent, you are going to require one of the antiplatelets lifelong. So sometimes CABG becomes more easier because you can, even in normal individuals, there is a data to take off antiplatelets after CABG, especially the arterial source has been used. And characteristic of an antithrombotic agent. What antithrombotic agent you are going to use, and you have to do the risk analysis of thrombosis and bleeding. And this is our data. Totally, we have got 15 patients. The 32-year-old fellow was the first patient we did 15, 16 years back when we had no factor. He came with MI and he underwent a primary angioplasty. He underwent a PAMI. So casualty called me, sir, this is a hemophiliac. I said, we'll give factor. We gave 1 dose of factor, brought his level, but I said, you treat him like a bleeding, any person coming with MI. I personally feel if a bleeding disorder fellow gets a thrombotic event like MI, the thrombotic stimulus is stronger. It has overridden the bleeding disorder. So he received 8 tablets of aspirin, he received tirafiban, he received Clexane, and he received 1 dose to maintain level at around 50%. And we hardly had factor in those days. So we said, look, this is, and he underwent a PAMI. He had a single vessel disease. We have to take chances and we'll give a dual antiplatelet for short time, and after 6 months, we'll put him on single antiplatelet. And that has been the policy even today. So we have had 15 total procedures. For some reason, hemophilia B, 11 patients were there. Of that, severe were 11, mild were 3, and moderate was 1. 5 had single vessel disease, 6 had double vessel disease, and 4 had triple vessel disease. So triple vessel disease went for straightway for CABG. Angioplasty was done, PAMI was done in 3, and medical management was offered to 2. And we have sent this paper for publication. Again, it will get published in coming months. I'll take you through some cases that we have managed over the last few years. He's a 29-year-old male, 66 kg, severe hemophilia. There was no inhibitor. Swelling on left thigh and knee slowly worsening over 3-4 years. Total EDs were more than 200. HGHS score was 6 out of 116, and FISH was 30. And this was a CT scan, CT angio of the thigh. He had a huge pseudotumor eroding into the femur, which was also eroding the knee joint that side. And you can see that he was going to need pseudotumor removal with TKR. Surgeons were not sure at this site whether he will also need THR. They thought it looks okay that we have got enough shaft, but we may have to be mentally prepared to do THR on table. So we took 1 week to get us that correct processes, and we did the procedure. So we use Adler Mediquip's mega processes. You can just attach to that processes a THR joint, and you can do in the same processes THR and TKR. Patient had only paid 1,000 rupees. He was a watchman's duty on some small factory, earning some 5,000-6,000. But our social workers raised money for him. Total duration of surgery was 11 hours. Transfusion support intra-op, he required 8 PCVs, 8 FFPs, and 8 crabs because he had that transient DIC-like picture. Factor VIII dropped to 40% when they touched and opened up a pseudotumor. A very huge pseudotumor. Now our policy is first to embolize the pseudotumor, reduce the size of pseudotumor. We did not do this here because already the femur was eroded. There's no point trying to reduce when we are going to remove the whole thing. He definitely needed the removal. Factor level maintained was 57% to 138% up to day 10. He was given low molecular weight heparin at 0.4 ml subcut OD. There was no post-op bleeding. After 2 days, the ambulation was started. Clips were removed on day 13 and 15. The total use of Eloctate was 39,000 units for this surgery. That came to 590 IU per kg. And this was the chart that how we replaced and how we monitored. You can see that we at least did 3 monitoring assays and twice we did inhibitor screen to document that he is still remaining inhibitor negative. And this was the post-op X-ray picture of the same patient. He's back to his work, doing excellent job in his duties. He has got married now and he has got one female child who will be obligate carrier. This is a case 2. He is 37-year-old male, 75 kilos, severe hemophilia with high titer inhibitor. Last year, we got some short expiry FIBA from World Federation and it was distributed to centers who could carry out inhibitor surgery. And we did in that 3 major surgeries for patients with inhibitor. All 3 underwent TKR because they needed TKR. But this was a unique case. So this was his course. And he had a huge pseudotumor engulfing the calf muscle, but not engulfing that side TKR. He needed TKR on other leg. You can see the pseudotumor and TKR requirement was the opposite leg. That was a boon. So both the things could be done simultaneously. Surgical team operating on the left leg, orthopedic team operating on the right leg. It was not an infected pseudotumor, so we could go ahead. And this was the MRI scan of the person. I won't go into the details of this. This was another MRI from another angle. And this was a CT angio. Any pseudotumor, we always do CT angio to find out what is the vascularity in the given area. So first surgery, pseudotumor happened. Pseudotumor was removed, which was 7.2 kilos. Okay. And then simultaneously he had a fracture on opposite side. The TKR was done. And this was the factor replacement. And we decided that we'll use lower dose FIBA and start something like an intermediate dose ITI. So we used enough factor rate. 50 IU per kg was given. And around 1 lakh unit factor rate was used. We had abundant of factor rate. And we only used around 67,000 units of FIBA for such a major surgery. And this was the external fixator with TKR. Orthopedic team did it on the same side. So factor and FIBA support was given for 14 days. Antibiotics were given for 10 days. I was really against it, but surgical team said, sir, better give antibiotics. I would not have given. This is the only time we gave antibiotics in a non-infected joint. The dose of FIBA for general major surgery is 150 to 200 IU per kg per day. We use 75 IU per kg per day. And using FIBA and factor VIII infusion as ITI simultaneously, we have dramatically reduced the dose of FIBA to be used in surgical procedure. And we have totally 4 surgeries using this protocol, but we want some more data to submit as a paper. But short communication we have done in ISTH meeting. This is the review article that we had reviewed. I am one of the authors on invasive surgical procedures in hemophilics from 3 different worlds. Cedric spoke about the high dose protocol. I have written about the low dose, and Elena has described about the non-factor therapies for surgical interventions. So CFC, there was a beautiful study done by ISTH in 2005 comparing the two dosages, and that became a landmark paper to start saying that low dose factor really works. It was not a randomized study, it was a data collection. CMC Vellore and our center, we put data from 98 to 2005, and a consensus said, okay, now we can acknowledge low dose replacement policy, it is safe, and it is endorsed. I would say nothing unethical to use lower dose. It has been scientifically proven. So I would say the take-home message would be that low dose protocols are effective. We can reduce factor consumption to 1/3 as compared to high dose replacement policy. It is not associated with significantly increased risk of bleeding or a delayed hemorrhage. So these are the 4 articles I would say that all hemophilia centers should have their downloaded on their computer. One is the European Principles of Hemophilia Care. There are 14 principles, and no European center is able to follow all 14 principles. So let us not feel only we may not be able to follow. On similar lines, we came out with an Asia Pacific perspective because 42% of hemophilics are in Asia Pacific, and there is extreme cultural diversity in these groups. And the World Federation guidelines is a 158 paper document, a beautiful document, all these issues covered. So hemophilia being a disease of really poor people, we have to always think of reducing the costs. I don't know whether Rajesh mentioned that we use our own harvested factor 8 and factor 9 deficient plasma. That really reduces the cost dramatically. Because in factor assays, the most expensive reagent is factor 8 or factor 9 deficient plasma. So laboratory tests performed in batches if required, but really we are able to do a lot of free work because of our other work. And as I said, hemophilia is an excuse for coagulation, not other way around. Okay. With that, I'll acknowledge all my colleagues. It is not a single person's work. I've been very lucky to have excellent colleagues with me in our institute. They're always willing to support our hemophilia cause. And with that team effort, we are able to control this phantom of the opera. A lot of young people are there. My generation grew up, he was my hero when I was a child, Phantom and Mandrake. And really, it's a phantom of the opera when a hemophilic goes for the surgery. Thank you for your kind attendance, and I would be happy to take questions.
Thank you, sir, for that excellent talk. And congratulations for all the guidelines that you have created for the judicious use of factors. Just a few questions from my side. Like when you said that there are guidelines to use high dose, and then you started first to use the low doses. How did now there are established guidelines that we can use low dose, but when you started, how did you come down to that particular dose? Number one. And second question is, can you guide us on, this was about joint replacement and other things, but before that, we have synovitis stage wherein we can inject some chemicals for the chemical synovectomies. So please enlighten us on that.
So basically, to answer your first question, while I worked in Vellore for 4 years, we had done 162 major surgical, no TKR, THR was done in Vellore between 90 to 94. But that gave me enough exposure and enough confidence, yes, it is working. It is working. In fact, in Australia, while I was there, it was a Christmas Eve. And our own severe hemophilia B patient came with a road vehicular accident. His sister was also there, she was dying. We did a hepatic replacement and cured that hemophilia B in the night. And we had used higher dose protocol in Australia. So if you have worked, that gives a confidence. We were worried. Will it have a legal implication? Because textbooks say this thing. Textbook says this thing. But after having done this for 4 years in Vellore, we had gathered confidence. We have not had any operative, none of the patients were lost intraoperatively or perioperatively. And that data, submitting and producing that data was very useful. Now they have been incorporated in guidelines. Now we are very safe. Older days, like when I did 2006, our first bilateral TKR, the factor positive was so low, we had used the expired factor, which was expired in 1996. There's nothing to expire in the product. Now we don't use. But what would you do when you have nothing? Okay. And your second question was?
Joint injections
Yeah.
for that chemical
So,
synovectomies.
if you are at the level of chronic synovitis stage, then the intrajoint radioactive yttrium, radioactive phosphorus, or you can use rifampicin. Radioactive yttrium costs around 56,000 rupees per dose, and half-life is only 3 days. Right now, we are doing a trial with BRC. BRC has come out with a colloidal P32. We have done 14 patients, and the cost per dose comes to 8,000 rupees with the half-life of 24 days. Phosphorus has a longer half-life. We had done this data a few years back on dogs. BRC was regularly producing crystalloid form of radioactive P32, and that was used in myeloproliferative neoplasms. So when they put colloidal P32, the idea was it will not have any systemic absorption. And we did that paper and we published that paper, but the person who did that retired and left, and nobody took an interest. But recently, new person has come, we reactivated that thing, and last 8 months, we have done around 15 or 16 cases with using radioactive P32. And it works beautifully. But it works at the stage of chronic synovial hypoplasia. Once there is a stage 4 arthropathy, it is useless because the joints are fused. You'll have to do joint replacement.
Tetracycline has been an historical, is it still indicated where we don't have access to these drugs?
Rifampicin is a better drug.
Okay.
Rifampicin is injectable rifampicin, works better, has a less local reaction. Post tetracycline, the local inflammatory reaction is too huge. And even in fluorodesis, tetracycline usage has gone down when other options have become available.
Okay. Yeah. Thank you, sir. Any questions from the house? Thank you, sir, for the excellent work. And I can feel the passion that you have for hemophilia and your subject. Congratulations. And we are really happy to have you, sir. Thank you very much, sir.
I request Dr. Sanjay Pakmode, he is the President-elect IP Nagpur, to kindly felicitate Dr. Amit Nemade, who is a pediatric orthopedic surgeon and he's part of the hemophilia management team at Lata Mangeshkar Birdy. There's slight change of sequence, and we are first going to take Dr. Savita Rangarajan's topic, that is from genes to gene therapy. She's joining us from Southampton, UK. And to chair this session, I invite Dr. Shweta Bansal. She's a consultant pediatric hemato-oncologist. Dr. Shweta Bansal, please.
Hi, hi, good afternoon, everybody. Can you hear me? Hello?
And to chair this session, I invite Dr. Shweta Bansal. She's a consultant
Hi,
oncologist. Dr. Shweta Bansal.
yeah. Can you hear me?
Yes.
Am I audible?
Yes,
Yes, ma'am. Yes, ma'am.
Yeah, thank you. Thank you very much. And many thanks to the organizers for inviting me to this wonderful meeting and to chair this session. And since morning, we have been listening about various aspects of the management of hemophilia. And with this, we have one goal, and that goal is that with hemophilia care, it is not to keep the patients alive who are having a hemophilia, but to help them to live their life to the fullest. And as elucidated by Dr. Apte in his talks, the quality of life improves dramatically by using a low-dose prophylaxis treatment with factor A and non-factor agents. And now moving forward in the same approach, and with Dil Mange More, we are now looking towards the cure for hemophilia. And one of the modality is gene therapy. And today we have none other than Dr. Savita Rangarajan to speak on this aspect. She is an associate professor at Southampton University in UK and is an expert opinion leader in the management of hemophilia. She is a frontrunner and has led many clinical trials in gene therapy in hemophilia, the reports of which have been published in top high-impact journals like Blood and NAGM. And now without much ado, would like to invite her for the talk and extend my warm welcome to her. Dr. Savita, please, I invite you for the talk. Welcome over here. Thank you.
Yeah. Thank you, Shweta, for that kind introduction. And thank you, Anju, as well, for inviting me to talk. I hope I'm audible. Okay. So, and thank you for the organizers for inviting me to this to the CME program. And I hope I can take you through this journey from gene to gene therapy for hemophilia. I'm very passionate about what has been achieved to date. And as is written here, we run a clinical trials and research unit at KJ Somaya, and we hope to run a very large hematology unit soon over there, which will hopefully take us through all this all over again. Thank you. So hemophilia, I don't need to talk much about it. I know you all are aware about it. And I will just say that there is a massive impact on the quality of life, which is what we want to change now. Given my provenance from the UK, I just wanted to talk a little bit about the history of hemophilia, because coming from gene to gene therapy, I thought giving the history is very important. It is called the royal disease, mainly because, not necessarily because of the cost and that only royal people can afford to pay out of their pockets, but actually Queen Victoria was a carrier for hemophilia, and that was hemophilia B. She passed on the gene to much of the European royal families. And I think the most famous royal person who had hemophilia was Alexei, the Tsarevich of Russia. And the history-wise, it's been known about fatal bleeding for a long, long time. In 200 AD, the Babylonian Talmud records fatal bleeding. And then it was only, although it was only in 1803 that John Otto presented an account of the hemorrhagic disposition in some of the males of a family in Plymouth, knowing that it was a X-linked gene. And the Tsar of Russia was so preoccupied by his son's ill health that he was unable to take firm decisions. I would say that led to the First World War and Rasputin's rise to fame for his ability to treat a bleeding condition. Leaving aside the history of hemophilia care globally, 70% have no or minimal treatment. Many die in childhood, and there is a high cost. Unfortunately, we do not have good epidemiological data in India as well. It's of a low priority for governments because of, in terms of its cost and the care. It is a rare disease, but although the numbers are low worldwide, it is not the case in India. All along, the development of hemophilia therapies was actually driven by safety needs. Meaning, we all know about that blood products or plasma-derived products prior to 1985, there were many issues. And that's why patients with hemophilia developed hepatitis B, hepatitis C, HIV, and many things. So most of the reasons the development of hemophilia therapies were actually driven by the safety needs or prevention of transfusion transmitted infection. And it was only in 1995 that Baxter Immuno started off the recombinant. In 1992 was a recombinant factor 8 that was produced. And then subsequently, much later, recombinant factor 9 was also produced. But for me to talk about the journey of gene therapy, I can't get away without talking about Professor Tuddenham, Professor Edward Tuddenham, who actually purified the chemical characterization of factor VIII by using Western blotting. This was in 1984. As you can see, that was a long, long time ago that they actually chemically characterized factor VIII, and also had the factor VIII clones that were expressed. So he was a man who actually originated the recombinant factor VIII. And I know Ted extremely well, and we have a great time talking on science. So he actually was the pioneer and a great giant in hemophilia. I don't say that his journey stopped at developing recombinant factor VIII. I'm sure you've heard about prophylaxis in hemophilia, but it was only in 2007 there was a publication which proved in a randomized study that prophylactic treatment was much better than episodic treatment for hemophilia. You've seen this slide, you have seen these joints many, many times. And of course, our goal has always been to stop the crippling effects of hemophilic arthropathy by giving adequate treatment. However, as Shweta already mentioned, Dil Mange More. Well, obviously, we don't want to stop at giving factor VIII and prevent bleeds. We want to improve the quality of life. We want to change the way hemophilia patients are, and therefore, we want these patients to completely integrate with society and feel that they don't have hemophilia. So that brought about disruptive technologies. Obviously, the potential for improvement over the current standards of therapy. As with any medications, risks are not obviously known, and there will be many unknown unknowns, and that only time will tell. And what is most important is first of all, to do no harm, and prior encounters with viruses, particularly in the hemophilia field, we are very wary of premature miracle therapies. So the replacement therapies with factor VIII or factor IX prevents hemophilic arthropathy in patients with severe hemophilia A, but the multiple intravenous infusions are required, and this is the same with hemophilia B as well. And hemostatic control of patients with inhibitors is difficult. The high cost of bypassing agents. To overcome these barriers, the disruptive technologies that we talk about, or I am going to walk you through, are first of all, emicizumab, which is factor IXA10 bispecific antibody, which acts like factor VIII, or it's a factor VIII mimetic. We have RNAi, or which is a small molecule RNA targeting antithrombin to reduce antithrombin, anti-TFPI antibodies, SERPIN-PC, and of course, gene therapy. So this is what it is in a nutshell. If I can show you, and I'm sure you can see my pointer. So as I already mentioned, emicizumab, we have anti-TFPI antibodies which act, and I will talk you through one or two slides with each of them. Tissue pathway inhibitor, siRNA, which is fitusiran, gene therapy. I don't have SERPIN-PC, but I'll talk about that as well. So multiple publications which I've been involved in, which have been mainly all the new molecules, but we are involved in many more, which I will talk about. Especially now that we have set up a very large clinical trials and research unit in Somaya, where both Shweta and Dr. Srimati Shetty are my colleagues over there. It is amazing to see what we can do. So as I've mentioned, do no harm is the principles. So I think given that emicizumab is licensed and it is licensed in India, we all know how emicizumab works. So it is a bispecific antibody. What does factor VIII do? Factor VIII brings the factor 9A and 10 together. That is the role of factor VIII. So instead of factor VIII, we have a bispecific antibody where one arm targets factor 9A and the other arm targets 10, bringing it together, acting like a factor VIII mimetic. So clearly, this is an amazing drug, and it has been used, and I think it is it's a blockbuster drug, I would say. And I think across the globe, for hemophilia A, this has changed the landscape significantly. The important features being subcutaneous use. It can be used for factor VIII patients with or without inhibitors, and it is unlikely to cause factor VIII antibodies or increase the antibodies or anamnesis, and it is an amazing drug. Yes. I'm not going to talk about this, it's the same thing. I'm going to move over to fitusiran. Now, fitusiran targets antithrombin to rebalance hemostasis with a goal to prevent bleeding in patients with hemophilia. As we know, hemostasis is a fine balance between procoagulants, and in this case, we are talking about factor VIII and factor IX, or if one of these are missing, and anticoagulants, and we have many anticoagulants in our bag. Fitusiran, in particular, is a small interference RNA targeting antithrombin. Now, what can I say? I'm working with Srimati, whose original article, which described antithrombin deficient patient and severe hemophilia, causing much, much lower bleeding, and in fact, the bleeding was hardly there, was what made Alnylam and others think about using siRNA targeting antithrombin to be a treatment paradigm for hemophilia. So thank you, Srimati, for the publication and the reason why we are here with fitusiran. So as I said, it targets siRNA and improves the thrombin generation and rebalances the hemostasis is such that the patients with hemophilia A, B, with or without inhibitors can improve their bleeding phenotype. As I said, it is a new class of innovative medicines. It harnesses the natural pathway using the catalytic mechanism to silence any gene in the genome. It is upstreams of today's proteins, that is mRNA. Of course, further upstream is gene therapy. And it is a clinically proven approach. And, as I said, the progress in the clinical trials are far-reaching. So moving on to another disruptive technology, which is anti-TFPI antibodies. So what does TFPI do? TFPI targets the external hemostatic pathway. So we have 7A and factor 10, which actually, along with the TFPI, so it actually, so what we are trying to do is take away the inhibitor of the clotting, of anti-clotting, in order to increase the clotting. So the anti-TFPI antibody acts against the K1 and K2 domain in the Bayer molecule, but which has been stopped because of thrombosis. And the anti-TFPI antibody acts against only the K2 domain, both in the concizumab and marstacimab antibody from Pfizer. So as I said, how does TFPI work? Tissue factor pathway inhibitor is a protein in the blood whose function is to block the activation of the extrinsic pathway in blood coagulation. So if you if you block the inhibitor, then you actually cause clotting. So I mentioned serpin PC. Now, serpin PC is a serpin which inhibits activated protein C. So we know that activated protein C is a catalytic protein for factor 5 and factor 8. So it targets factor 5, factor 8. So what we want to do is to inhibit activated protein C. And alpha-1 antithrombin, or the mutated version of alpha-1 antithrombin, is called serpin PC. And that is what inhibits activated protein C. So what we know, again, going back to the theory about the balance of hemophilia by decreasing the anticoagulant. So what here too we are doing is decreasing activated protein C, which is an anticoagulant, by inhibiting it with alpha-1 antitrypsin, which is a mutated one. So moving quickly on, knowing that I'm keeping to my time, moving goalpost with investigational gene therapy trials. And obviously, we all know that one of the most important gene therapy trials has been, gene therapies has been licensed in FDA as well. I'm going to show you a video.
My main reasons was for my family. Well, I've got a daughter with the carrier gene, and I was concerned for her future and my future grandchildren. So I wanted to try and see what I can do and make a difference to help improve their lives.
I felt as if it was my duty to do it. I think it's something that needed to be done. As you know, when I grew up, I spent the majority of my childhood in hospital and in bed recovering from a silly little bleed that I don't remember doing. And while in there, I'm always thinking to myself, oh, I wish I was like the other kids. Growing up in South Africa, you know, the sports there are quite big: rugby, cricket, football, and why can't I do that? Why am I here? And I don't want the future children to ever go through that, ever. And if taking part in this phase 1 study is the first step for that future, I'm all in.
I was brought up to know that this was an incurable condition, and now, in theory, I'm cured. You know, it's amazing to actually be part of that, and to actually be one of the first to experience that. I had hemophilia all my life, and I grew up with it just being there. I didn't know any different, and now I didn't realise actually the effect it had on my life before. Simple things like taking the medication, being very conscious about what you're doing.
As a hemophiliac, every day is a risk. Every day you're taking a chance. When you're walking across the streets or you're just going shopping, anything could happen to you. So when you're given the opportunity to take a risk and change the world, why not? Why not be the first? Why not be the 10th? My mother always said to me is be the change you want to see in the world, and I believe it starts with you.
So that was the beginning of a cure. I mean, I remember this journey very, very well, and I'm so pleased to be part of this journey. And I don't think I can ever get myself out of this, because you know, we were part of those two of my patients were part of the phase 1 study. In fact, one of them, a very young man, was the first patient ever for gene therapy in hemophilia A. And, you know, he was amazing. So I think this has been an amazing journey personally for me, but I think for the whole community for hemophilia. And I tell you, this is not, I don't think I would ever get away from this whole history of hemophilia. So as I said, I was, AAV mediated gene therapy is where you package either factor 8 or factor 9 into a vector, which is basically a vehicle which takes the gene of interest into the body, into the nucleus, into the cell of interest that you have. And in this particular case, we are talking about liver being the cell of interest, liver cells being the cell of interest. So we package the factor 8 or factor 9 along with its other elements that it needs to produce the factor 8 protein or 9 protein, put it into the vector, which is a degutted adeno-associated virus, whichever serotype it is. We used AAV5 in the biomarin trials, and AAV8 or AAV3 has been used in other studies. So then it goes into the liver cell, goes into the nucleus, the virus capsid breaks down the gene of interest, goes into the nucleus, it sits in the side, it's an episome, it doesn't integrate, and then starts magically to produce the protein of interest, either factor 8 or factor 9. So what are the goals of gene therapy in hemophilia? We want a sustained factor activity levels without the peaks and troughs, continuous expression versus intermittent expression depending on the timing of replacement. And then it is a single medical intervention versus a lifetime of repetitive intervention. We all hoped, even if we reached just 10 or 12% of factor activity, it's enough, because we know that mild hemophilia A patients or B patients with levels of 12% and above do not bleed. So that's the target that we went for. However, we achieved differently, but that's a different matter. That's history. And it was amazing to see the factor 8 levels go up and up and up. So the continuum of gene therapies, we have different approaches. Obviously, what I have talked to you about is in vivo gene therapy, which is the easiest. Then, of course, we have gene editing, where you can actually edit the gene either in vivo or take the body's cells out, edit, and then reinfuse. The complexity increases with the different approaches. And why gene therapy for hemophilia? For researchers, it's a perfect disease to study because it's a single gene defect. We have a wide range of benefit. As I said, 5 to 150% of factor 8 or 9 is okay. And you don't require a tight regulation. And this was an old slide. Obviously, many more gene therapies have been licensed since then. And the high burden of current standard therapy and the continued risk of morbidity and mortality despite prophylaxis. And 70% of the world, as I said, has no access to clotting factor or adequate clotting factor, I would say. So I'm talking about the biomarin study, which is the AAV5 factor 8 SQ, which is similar to Refactor. And this is the genomic construct. And ApoE was the A1AT was the promoter, which is a liver-specific promoter for this study. So how do you evaluate dose in gene therapy? There's a lot of interprogram variability in dosing. And what is important is that because it's a biologic, we still have a lot to learn. So even though some of the drugs, some of the gene therapies have been licensed, I think we are just in the start of our learning curve. And what we need to understand how dose relates to safety, efficacy, and durability. And I can show you some examples of why I say this. And how do you evaluate safety in gene therapy? Well, we do seroprevalence to understand. As I mentioned, there are multiple serotypes. We need to make sure that the patient doesn't have antibody against AAV serotype prior to giving the gene therapy. However, one of the gene therapies that has been licensed, they actually didn't look at the seroprevalence of the patients they took into the study, and they were able to show good factor 9 levels. There's also transaminitis where the liver gets inflamed. So we do see ALT, AST go up, more ALT. We have to give steroids. Potential for genetic integration, but however, we have not seen that with AAV. There is a potential for inhibitor formation. We haven't seen that yet. And we have to look at the vector shedding and how long it takes for all the viruses, the billions of particles of viruses that we give to get out of the body. How do you evaluate efficacy? Primary is about factor VIII activity levels, whether we reach the ideal target levels, and also the patient populations, which are the patient populations that we can target and get through. The secondary ones are impact on factor replacement, impact on annualized bleeding rate, impact on quality of life. So these are the kind of things that we would evaluate efficacy from gene therapies. Again, in the interest of time, I'm not going to go through all the details of the biomarin study, but we did achieve, as you can see, we achieved a factor VIII level in the phase 1 study within the first year or so at very good levels, well within the normal range. And this was the annualized bleeding rate after gene therapy, hardly any bleeds. And the annualized factor usage was also decreased significantly. So as I said, this was the first gene therapy for adults with severe hemophilia A to be licensed by European Commission. This was in August 2022. What is important, I mentioned, because of the way it is, I talked about the trial design, important to understand the intervariability, that, it is so variable. And, as you can see, this was the Freeline Therapeutics trial design, which was published in New England Journal of Medicine. They went up and down with the dosage in order to be tight in their factor IX levels that they wanted to achieve. Unfortunately, it just shows that your factor IX can go up and down by changing little bits of the amount of the vector you give. They have pulled the trial, so they are not going ahead with the phase 3 trial. This, on the other hand, was a uniQure phase 3 trial, where it was quite steady, and they got really good results with the HOPE-B trial design as well. And as I said, the aim of gene therapy for the uniQure HOPE-B was, it is a Padua mutation packaged into AAV5, similar to biomarin, the same serotype, as you can see. And they got really good levels, and I can tell you 50%, almost 50% factor IX levels in most of the patients, although their average median was 39 to 40. I know all of you must have seen this. It was the world's most expensive treatment at 3.5 million, move over all the other gene therapies. So it seems to be a competition to increase the amount of the most expensive drug that is available. Obviously, the uniQure has been brought to, the licenses have been given to CSL Behring, and therefore it has been approved to treat hemophilia. What about AAV gene therapy in children? Given that it's a non-integrating virus, sorry, I think it's, Given that it's a non-integrating virus, it forms episomes and some are lost in the cell division. Liver in children is rapidly growing, and the safety benefit risk in children, we don't know. As I already said, known unknowns, unknown unknowns. So we don't know what will happen in many years to come. High cost, complexity in manufacturing, high inefficiencies throughout. We don't know. We don't know about AAV antibodies, high interpatient variability, and how do we manage the transient transaminase elevations? As I've already mentioned, what about children? Are there other solutions, including gene editing and perhaps non-viral vectors? So that's my story. And I believe people can't see me. I need to, let me try and see. Yeah. Can you see me now?
Yes, Dr. Savita, we can see you. Thank you very much for excellent lecture.
I'll stop sharing. Yeah.
Yeah, it was an excellent lecture, actually. Thanks for taking us through the journey of the development of hemophilia treatment and patiently talking about the gene therapy and its clinical trials in hemophilia. So, house is open for the questions. One question from my side. What is the exclusion criteria of hemophilia patients in these clinical trials of gene therapy? I'm talking about
Well,
exclusion rather than inclusion criteria. So,
yeah,
which
exclusion would be mainly liver related. And obviously, we had patients with previous inhibitors were not taken in as well, current and previous inhibitors. We did not have patients with liver disease in terms of hepatitis C, because we know that patients with hemophilia had, because it's targeting the liver. Those were the main exclusion criteria. And obviously, it was greater than 18 age.
Okay. Now, going forward, how do you see its development in the country like India? Do you think it's going to come, and what care we should take for our patients so that they can be eligible for gene therapy, clinical trials at least?
I think the most important thing is to obviously have good data in their in terms of their inhibitors, non-inhibitors, liver disease. I mean, although we did not exclude patients who had hepatitis C in the past and had cleared it, so they were all eligible as long as they did not have ongoing hepatitis C. So that was the most important thing. So that's the other aspect. And I think obviously AAV antibodies were an excluding, if they had AAV antibodies to that particular serotype. Certainly from the biomarron, we excluded patients, but Unicure didn't exclude patients. So it's something that can be looked into. So we are doing seroprevalence studies now, or we have done some. So let's see. I think I'm looking forward to the next year or two where we will have gene therapy trials in India. And certainly, I think Shweta and Srimati, I know I'm talking to all of you, but we hope that we will be doing some trials soon in Somaya.
Thank you very much. Any questions from the house over there?
Can't hear you. Please, can you mute?
Anju, we can't hear. Yeah.
Hello, am I audible now, ma'am?
Yeah.
Ma'am, good afternoon and thanks a lot. Thank you so much from the house for taking out time on this Sunday, and that too at 8 a.m. in the morning in England. Another thing, ma'am, there has always been an issue about sustainability of the levels after the therapy. So what is your take on that, ma'am?
So that is to do with factor 8. Factor 9, I think, is sustainable. So we have, as I told you, this is the journey we are just starting. We have a lot to learn. And there are theories about why the factor 8, and it all depends on the amount of virus particles that you give and the immune response associated with it. So I already told you that these are episomes and they are not integrated. And therefore, when the cell divides, you may lose the expression. So we don't know how we are going to, and we also know that the factor 8 is not usually produced in the liver cells. It's actually produced in the endothelial cells. So the protection with von Willebrand isn't there. So there are many reasons. We hope to find the reasons. And I think this is just, what can I say, version 1.0. We will have many versions of gene therapy. So we are just at the start.
But it's quite encouraging what we say, that the eradication of genetic disorders only by stopping or breaking the change or just completely removing it. Thank you so much for taking up this initiative, ma'am.
Yeah. Thank you.
Thank you.
Thank you so much. I would like to extend my heartfelt thank to Dr. Shweta madam, who was there online to chair this session. Thank you so much, ma'am, for being there. And thank you for starting this wonderful unit at your setup.
Thank you so much. It was a pleasure to chair this session. Very interesting. Yeah.
Thank you so much. Thank you, ma'am. Good day. With this, we move on to another very important topic in a genetic disorder, that is the prevention. So for this session, we have Dr. Srimati Shetty Madam from all the way from Mumbai. Due to last unforeseen circumstances, we could not be here in person. So for this, to chair this session, I request Dr. Rugwani sir to kindly come forward. Vinky Rugwani sir is the president of Thalassemia and Sickle Cell Society. Sir has been the member of Maharashtra Medical Council. Over to you, sir. I request Dr. Fadade sir to please come and chair the session. And over to you, sir, please.
Good afternoon, everybody. Very important, as we always say, that prevention is always better than cure. So, especially in genetic diseases, this particular version is always make a sense. We have an eminent speaker, Dr. Srimati Shetty. She is currently working as a director, laboratory hematology and clinical research at KG Sumaya Hospital and Research Center. She is former scientist at ICMR, more than 30 years of research experience in the field of thrombosis and hemostasis, 270 plus publications in the journals. So over to Dr. Shetty, please.
All right.
Yeah, madam. Yeah, madam, you can start, madam.
All right. Yeah. Thanks. I'm grateful to Nagpur Hemophilia Society as well as the Academy of Pediatrics Nagpur chapter for giving me an opportunity to talk to this august gathering. So I will be, as usual, I'll be talking on carrier detection and antenatal diagnosis in hemophilia. I'm currently affiliated to KJ Somaya Super Speciality Hospital in Mumbai. I'm being appointed as the Director of Laboratory Hematology and Clinical Research after I got superannuated from NIH ICMR. So any comprehensive hemophilia care center, genetic diagnosis is an integral part, along with laboratory diagnosis, clinical management, and the rehabilitation. So now when we talk about a bleeding disorder, it's not always hemophilia. You have a variety of bleeding disorders, though they are rare. You have the coagulation factor defects as well as the platelet function defect. Hemophilia is the commonest among all the bleeding disorders, and hemophilia A is the commonest. Now, just to give you an idea of the ratio of these different bleeding disorders, these are the bleeding disorder patients whom we have diagnosed at KEM Hospital. As you see in the pie diagram, hemophilia A is the commonest. 75% of the patients with bleeding disorders who present to the hospital are hemophilia A. Around 14% are hemophilia B, and the remaining are von Willebrand disease and rare clotting factor deficiencies like fibrinogen disorders, factor 2, factor 5, factor 7, factor 10, factor 11, 12, and 13. And you also have platelet function defects who present to you with bleeding. And the commonest one is Glanzmann's thrombasthenia, followed by Bernard-Soulier syndrome. Then you have very rare platelet function defects like storage pool defects. And you also have several patients who are they present with platelet function defects, but they're not classified into a definitive disorder. So you generally tend to do a next-gen sequencing to offer a diagnosis in this group. Now let's come to hemophilia. I'll be talking on genetics of hemophilia, the carrier detection and antenatal diagnosis. You have hemophilia A, 1 in 5,000 males. This is the Western data. Hemophilia B, 1 in 25 to 30,000 male births. Now you have two distinct genes, two distinct proteins, but the clinical manifestations are almost similar in both these disorders. So you need to have a laboratory to diagnose whether the patient is hemophilia A or hemophilia B, factor VIII deficiency or factor IX deficiency. Now, this is an arbitrary classification of the laboratory. The severe ones are less than 1%, factor VIII or IX. Moderate ones are 1 to 5%, and mild hemophilia are 5 to 40%, either factor VIII or factor IX. Now, coming to the genetics of hemophilia, we know that it's an X-linked recessive transmission. Males have only one X chromosome. So if there is a hemophilia gene in this only one X chromosome, they manifest with bleeding. Whereas females have two X chromosomes. One of them is affected, carries the hemophilia gene. They're called as carriers. And the other one is normal. So they don't have generally, they don't have the clinical manifestations. Now, hemophilia it is not always familial. All of a sudden, you have a lady walking in with the hemophilia child without any family history. And this is roughly 1/3 of the hemophilia patients whom we see in the lab are sporadic or de novo cases. So remaining 70 to 75%, they have a definitive family history, one or the other family members being affected. Now, this is a rough figure. You have roughly 130,000 hemophilia patients in the country. We don't have the prevalence data. This is just a figure which is translated from the Western data, translated considering the population of India. So you have an annual addition of, I said, there is a new mutation which is always happening in hemophilia. So you have an addition of 1,500 annually. So the projected number of potential carriers, if you take 5 to 6 female who need a carrier testing, it works out around 8 lakh carrier women. And if you say that 1 in 2 are a carrier, you have around 4 lakh carrier females who need prenatal diagnosis during their pregnancy. But how many genetic diagnosis centers we have in India to cater this to this big number? We have hardly 4 or 5 centers in the country working on offering genetic diagnosis to these hemophilia carriers. So the only way to prevent hemophilia as of now is to identify the carriers and offer antenatal diagnosis. It is not possible to totally eradicate hemophilia from the society because 1/3 of the mutations are due to new mutations. So new mutations keep happening in hemophilia, in factor VIII and IX genes, but you can always reduce the number of hemophilia patients in the country so that the existing hemophilia patients get the best of the facilities. Now, the attitude towards prenatal diagnosis varies in countries. If you go to Western countries, prenatal diagnosis is not being given so much importance as it is in the developing countries. So if you see this slide, this is a slide from prepared from the data of the WFH survey. This is a little older 2015 survey. The per capita consumption of factor VIII, is the lowest in India compared to some of the developed countries like UK and US. It is 0.067 as against 14.8 and 8.25 in US. So it is much lower. We need to reduce the number of hemophilia patients by way of carrier identification and prenatal diagnosis to the confirmed carriers. As I mentioned, the demand for prenatal diagnosis depending on how good quality of life in a hemophilia A patient is. So it is directly proportional to that. Now let's look into the inheritance pattern of hemophilia. Now the different combinations. This is a very important combination because both the parents are non-bleeders. A normal male getting married to a carrier female. She is a silent carrier and she transmits her gene to half of her male sons, and I'm sorry, and half of the sons are normal. Similarly, the daughters, half of them are normal and half of them are carriers. So it is this combination which needs the genetic diagnosis. We need to identify this silent carrier before we give it. Now, here you do not need a genetic diagnosis. A hemophilic male getting married to a normal male, because he gives his only X chromosome to his daughters, all his daughters are obligatory carriers and all his sons are normal. This combination does not require a genetic diagnosis. Sometimes we get families traveling thousands of kilometers for a genetic diagnosis in such a family. The father is hemophilic, go for genetic diagnosis to the lab. So we don't need a genetic diagnosis. It's only that the daughters, when they conceive, they need to come for prenatal diagnosis to the lab. Now, a female hemophilia is possible when such a combination occurs. A hemophilic male getting married to a carrier female, you can have a hemophilic female along with hemophilic males in the family. Now, hemophilia carriers, as I mentioned, can be obligate carriers. They don't need genetic diagnosis, or potential carriers. We do not know their carrier status, but we have to do a genetic diagnosis to identify whether she is a carrier or a non-carrier. Now, who is an obligate carrier? A woman having 2 sons with hemophilia, you don't have to do a genetic diagnosis. She is a confirmed carrier. The mother is a confirmed carrier. Having 1 son and another relative in the family, she is also a carrier, or a daughter of a hemophilic patient. Now, this is how the obligate carrier, the father is hemophilic, both his daughters are obligate carriers. So who are the females who need a carrier diagnosis in the family? If a mother is having only 1 son and she doesn't have any relatives, that mother needs to undergo carrier testing. Though we know that 70 to 80% of the time such a mother is a carrier, but she needs to undergo a genetic diagnosis to confirm her carrier status. Sister, this is an important group. All sisters of a hemophilia patient should undergo carrier testing before they get married or before conception. Aunt or the maternal cousin, if the hemophilia is from the maternal side. So this is what I said. You have a sporadic case. The mother doesn't, I'm not very sure whether the mother is a carrier or a non-carrier. You need to undergo a genetic diagnosis. Hemophilia in females can occur when a hemophilic male marries a carrier female, or in case of Turner syndrome, where she has only 1 X chromosome, or there is a very rare genetic phenomenon called as X chromosome lionization. Even a heterozygous carrier can present like a hemophilic male, because the X chromosome is getting inactivated here, and her factor VIII level can go as low as less than 1%. All bleeding disorders are not X chromosome recessive. You have some of the subtypes of von Willebrand disease and rare clotting factor defects, as well as platelet function defect, which are autosomal recessive. And these are more common in consanguinity, where the parents are related before getting married. Now, these are some of the questions which are being raised by the family members of hemophilia. So I have put the questions and I have put the answers below. Who are the essential members required for genetic diagnosis? Any one index case. It can be affected brother, maternal uncle, father, parents if available. And what is essential, as I mentioned, is one index case to give a carrier diagnosis for all the female relatives in the family. Who should get the carrier status? I have already covered this. All sisters, maternal, paternal, aunts, depending on which side the hemophilia is, all cousins. In other words, all female relatives of the affected case. It's better if the family members come to the center and give the samples to have a detailed family pedigree as well. When should I get my carrier status? This is a question which is being raised by many of the family members. What I would advise you is ideally before getting married and before conception. But what is happening these days is some of the carriers have lower levels of factors because they may need their factor levels as well. So they can get the factor levels even before getting their carrier status. What gestation period is when should I'm a confirmed carrier, when should I do a prenatal diagnosis? Ideally, and it's always the best, first trimester between 10 and 12 weeks. You need to contact the lab probably once you confirm your pregnancy, and along with the sonography report, you need to contact the lab, and the lab will give you the date for prenatal diagnosis. Second trimester, it is all, I mean, even if you miss this window, 10 to 12 weeks, you have 16 to 17 weeks period. That is for amniocentesis. You can still go for diagnosis, and the reporting time is 7 to 8 working days. If you miss this, even the 17 weeks, we still take the families between 18 to 19 weeks. I would never advise the families to go for this period because it's much later. The laboratory needs some time to give diagnosis, but we will not turn back the patients. We still go with the diagnosis. We collect the cord blood sample and give the report within 1 to 2 days here. Can we know the sex of the fetus? Many of the families sitting, ideally almost all the families sitting in front of me ask whether they can know the sex, which is not possible. The reports are only of 2 types, affected, unaffected. So I counsel the families, what does affected mean? Affected means hemophilic male. Unaffected means it can be normal male, normal female, or carrier female. Every family wants to know the carrier status if it is a female fetus, which we are unable to give because the government does not allow us to give a carrier female report because it's indirectly a sex report. So this is not possible. Do carriers have a risk of bleeding? About 30% of the carriers have less than 40 to 50% of the factor. This is what I said. The factor levels range as low as 6%, whereas some of the carriers can have as high as 150%. It depends partly on the blood group of the patient or the female. O group has the lowest range of factors compared to A or AB blood group. Therefore, it's very essential for the carriers to know their factor levels because as they move ahead, if they have to do some surgeries, it is better to carry a factor level report when they go for some invasive procedures. Do we need all family members? If you do not have, because these days the diagnosis is given by direct mutation identification, unlike the earlier times where we used to give by gene tracking analysis, where having all family members was essential. But now, even without family members, we can offer a diagnosis. Can samples, we do accept the samples sent by courier, but the samples need to be collected after talking to the lab, and as per the instructions, the samples need to be collected. Can it be kept confidential? Yes, we can. Cost of the test, we charge, being a government institute at KEM Hospital, rupees 6,000, either for carrier detection or for antenatal diagnosis. But for antenatal diagnosis, the radiologists charge around 5,000. So if a patient or a family is a BPL card holders, there are no charges, but the radiologist will take his charges of 5,000 for prenatal diagnosis. Misdiagnosis, very low. There is a risk of misdiagnosis. How to offer a diagnosis when the index cases? Now, because many of the families might have lost their index cases, we can still look into the mutation in the carrier mother of the index case. Sampling, there is a risk but in our 2,000 or more families, what we have done, we do not have any miscarriage due to the procedure itself. Many of the, we are getting families where the labs do factors in a carrier, in a potential carrier, and they say you are a carrier. This is totally wrong, because there is a 10 to 30% rate of misdiagnosis by classifying a female as carrier or non-carrier based on factor levels. Genetic diagnosis needs to be done to classify them carrier or non-carriers. These are some of the children where we have done an antenatal diagnosis in carrier females and have issued normal, they come for a follow-up analysis to us. Now, these are the different fetal sampling techniques in different gestational ages. 10 to 12 weeks, we do a chorionic villus sampling. 16 to 17 weeks, we do amniocentesis. And 18 to 19, we do chordocentesis. But this is the time we need the families to report to us. 10 to 12 weeks, much before you have to report to take an appointment in this window of pregnancy. What we do is the sample, it's a placental biopsy being done by an expert radiologist. They send the sample to the lab. We put it under dissection microscope. This is how it looks, the chorionic villus. And then we separate out the chorionic villus sample from any maternal contaminated tissue. And after that, we do the DNA extraction and subsequent genetic analysis. This is one thing which is still in the research area, non-invasive. At the moment, it's a trans-abdominal chorionic villus biopsy procedure done by radiologists. Without that, can we offer a diagnosis of the fetus, non-invasive genetic diagnosis? We have 1 or 2 research projects ongoing at KEM Hospital at the moment, trying to collect the maternal blood, separate the fetal DNA from the maternal blood at 8 to 10 weeks of gestation, and then put the DNA for genetic to say whether the fetus is hemophilic or non-hemophilic. It will come, but at the moment it's in the research area. It will take some time before it becomes a routine practice. In that case, a pregnant mother can come at an appropriate time during early pregnancy, give 10 cc of blood sample and wait for the report of the fetus to get a report whether the fetus is affected or unaffected. This is another area. We still do not have this kind of diagnosis for hemophilia pre-implantation, whether the ova can be picked to say, because carriers have normal ova, carriers have hemophilic. So whether we can take a normal X chromosome ova and then do a IVF and kind of procedure. This is called pre-implantation genetic diagnosis, so that you don't have to go through the chorionic villus sampling and then terminate the pregnancy if at all it's found affected. Now, a little bit on the technique, what we do in the lab for genetic diagnosis. Unfortunately, all coagulation factor genes, which we do not know why, the genes are pretty big. And if you compare to beta globin gene of thalassemia, it is just 2 kb, whereas we are dealing with a 200 kb, 186 kb size, 200 times bigger than the thalassemia gene. So when I say the size of the gene, it is so tedious to look for the mutation. That is the reason we say that you come to the lab much before conception or pregnancy to identify whether you are a carrier or a non-carrier. You are giving much time to the lab to designate you as a carrier or a non-carrier, because the genes are big, the mutation, the large size, the mutations are highly heterogeneous. Sometimes you need to look into 2 or 3 genes like factor 13, fibrinogen. You need to look into multiple genes to look for the mutation. 1/3 of the mutations are new mutations. Then besides, there are other problems like mosaicism. In VW, we have a big pseudogene. So giving the genetic diagnosis is extremely difficult in a coagulation lab. Besides, it is carrier identification and antenatal testing. Identification of mutation has various other benefits, because The mutation is one of the strongest, the type of mutation is one of the strongest factors for inhibitor development. I'll show you, this is one of the PhD projects where if you see 8 patients had large deletion resulting in hemophilia, and all 8 patients are inhibitor positive. So the type of mutation is also a risk factor for inhibitor development. Now, coming to the type of mutations, we always look for common mutations because it's much easier for genetic diagnosis expert. 50% of our severe hemophilia patients have a common mutation called intron 22 inversion. So our strategy now is to look for this mutation, and once he's positive, we are in it. Once he's negative, we need to go ahead with with scanning the entire 200 kilobase area. These are different techniques which have developed for intron 22 inversion. This is currently the technique because this is a cost-effective technique. At the same time, it's very accurate for intron 22 inversion, which is called as inverse PCR. Subsequently, we got another common mutation, but we have only in 2 to 3% of severe hemophilia patients. This is intron 1 inversion. You have a short PCR, multiplex PCR technique for identifying. If none of the PCRs, you get the amplicons, then you suspect deletions, and you have another technique for identifying deletions called multiplex ligation dependent probe amplification, MLPA technique. This is the age-old RFLP technique. We started with this technique we are not identifying the mutation here, but now because of the accuracy, you need to look for you need to identify the mutations directly and give a diagnosis. So this is an outdated technique. So these are some of the pre-screening tests like CSGE. You look for a particular fragment where the mutation is located, and then you do a DNA sequencing. Once you get a change in your sequence, you need to take the help of bioinformatics to see whether these changes are pathogenic or non, because in your whole DNA segment, you have both pathogenic changes as well as non. So you need to identify with the help of some of the predictions of. So it's a very, the reason for me to show these slides is how tedious the techniques are before we offer you the diagnosis. This is very important for the families to know. Even after applying all these techniques in 2 to 3% or 1 to 2%, I can say, you are not able to identify the mutations. So what are your options? Either you do a cord blood sampling and do a phenotypic, which I would not advise, but you have some high-end techniques to identify mutations deep within the introns. It's not in the exonic area where we generally sequence. So now we have a very good strategy how to have a cost-effective genetic diagnosis. We look for the common mutation, then we go step by step to identify the mutations. This is for hemophilia A and hemophilia B. Now, before I wind up, I just want to show you this slide. This is a point of care test which we have developed for hemophilia A and von Willebrand disease. You just add 50 microliter of the plasma of the normal and the patient, and within 10 minutes, you can offer it. This is how a normal looks like with 2 bands, and this is how a hemophilia patient, only the control band will be seen, and there is no patient line. This is the company which will come out with this kit in the next 1 month to 4 to 6 weeks. This kit should be in the market, and the cost of the kit, the final cost of the VWD diagnosis is 70 rupees, and hemophilia is slightly higher, between 150 to 200 rupees by the company. So this is a comparison. My cost in the lab was less than 50, but when it goes to the company, they add multiple, even then it is much, much lower. Within, 70 rupees compared to some of the 7,000 rupees for a VWF antigen and platelet aggregation test. This is hardly anything. And you don't need any equipments and technical expertise. And with just any lay person, even in a primary healthcare, so you need a citrated blood sample and you have to separate the plasma by spinning it. But recently we have also done it for the whole blood, the citrated blood. Even by adding 50 microliter blood, within 10 minutes, you can offer a diagnosis of von Willebrand disease and hemophilia A. So very soon it will be coming to the market, and everybody. This is some of the camps what we have held for carrier detection, but we have issues in holding camps for carrier detection because large number of samples, we do not want to make an error. So we advise the families to visit the center with their family members for genetic diagnosis. With that, I close here. If you have any questions, you may go ahead with the questions.
Thank you very much, Shetty ma'am, for this very nice and brief introduction about the genetic testing in hemophilia, and really encouraging to have this card test for the benefit of the patients, the people with hemophilia. Thank you very much for that. And just one small query about the card test, whether it is going to detect the genetic, means the, what I can say, the carrier level, or it is the, what exactly it is detecting?
No, it is only for factor 8 levels. It's an immunological assay. So it's only at the moment, any severe hemophilia, we have kept a cutoff for 5%. So anything lower than that, you won't be able to see any line in the test, any band in the test line. So anything more than that, depending on the factor 8 levels, you get bands of different. So no band, he's a severe hemophilia A. So any faint band, he can be either mild or normal individual. Yeah.
Okay, that's really encouraging, ma'am. Thank you very much. Any questions?
Good afternoon, ma'am.
Good afternoon.
I mean, indeed, was a very lucid presentation, ma'am. This point of care thing, I mean, which you have already talked about, the blood thing that you said, it will be for von Willebrand as well, or only for factor 8?
For both von Willebrand as well as factor 8. It's only that the company has to put some additional filters to filter out the RBCs. So the cost will be 10 to 20% more than the plasma kit. But it's highly useful because many of the remote places may not have a centrifuge even to spin the sample. You just have to have a citrated blood sample. You just add 50 microliter of the blood sample, and within 10 minutes, you have a clear band. And I have seen the results comparison between the plasma and the whole blood. They work equally well. So that's another addition we are making. But first thing which is going to be released in the next 4 to 6 weeks is the plasma kit. But once it's in the market, immediately after that, we'll be also releasing the whole blood kits. Yeah.
Thank you, ma'am.
I think a wonderful presentation of a complex topic, I suppose, in a very simplified way. Really, this particular part of this hemophilia, that means this antenatal testing is a must, as we all know that prevention is a part of doing something good for these patients. Thank you so much. Thanks a lot.
Thank you.
Thank you so much, madam.
It's a pleasure.
Thank you so much for joining. And with this, we'll be concluding this this session because there are no questions from the audience. And madam, you have been very, very elaborate and specific. The basic questions that we face, like cost, when should they come, and who should contact the genetic people, and all the questions have been beautifully answered by you, ma'am. Thank you so much, ma'am.
Thanks. It's my pleasure.
With this, I'd like to thank our chairpersons for the session. Thank you, Fatade sir, and thank you, Rugwani sir, for chairing the session.
Now, what are the intensities that can be used by a hemophilia patient to treat a joint or to make the joint healthier? It was found that the strength of the strength lower than the healthy individual's strength is effective in treating the hemophiliac patients or to increase the strength of the hemophiliac patients. Resistance exercises seems to be safe intervention if it is adequately monitored, well adapted by a patient and applied with a sufficient factor therapy. That means with a prophylactic treatment. Now in this picture, we are seeing the various muscles that are involved. In upper limb, it is deltoid, bicep, forearm muscles, supinator, pronator muscles. In lower limb, it is observed that iliopsoas muscle, thigh group of muscles and calf muscles, along with buttock muscles are more involved. And in upper limb, joints that are taking stresses like shoulder, elbow, wrist, fingers, and in lower limb, hip, knee, and ankle are more involved. Hemophilia causes hemorrhages, mainly affecting the large joints and muscles. Recurrent hemarthrosis leads to chronic hemophilic arthropathy, which is associated with reduced strength of the muscle, further reducing the muscle atrophy, and which causes the shortening of the muscle, hence contractures, angular deformity, and finally leading to the ankylosing joint and disability. Strength training founded that it improves the bone mass and can reduce the pain and disability. For example, in person with hemophilic arthropathy, strength training exercises combined with coordination and endurance training is important to improve the joint stability and to control the exaggerated end range of motion, thereby reducing the risk of injury, fall, and hemarthrosis. Hence, it was found that physical activity well adapted should be included along with the muscle strengthening weight-bearing activities to promote the bone density by the World Hemophilia Federation. Strength training not only builds the muscle strength but also decreases the frequency and severity of bleeding episodes and associated pain. There is the scope of advances. Advanced scope is there. Recent studies have shown that hydrotherapies has proven effective in strength training programs for hemophilic patients, causing reduced bleeding episodes and thereby reducing pain. Scope of the further studies will improve the scope of treatment with patients with hemophilia and thus enhancing the quality of living. These are the some references which have been found. Thank you so much. If you have any question, you can please.
Can you please elaborate the role of isometrics and how to progress with isometrics in hemophilia?
In basically, when the joint bleeds, we start with the isometric exercises to reduce the bleeding tendency of the joint. Isometric exercises are performed with the contraction of the muscle. For example, if the knee joint muscle is involved or knee joint is involved, then the patient is asked to contract the quadricep muscles without lengthening it. So isometrically contract the muscles. So the strength of the muscle gradually improves, and then we can ask the patient to jump into the another level of exercises that are dynamic or isokinetic exercises.
Right. Thank you. Thank you. This is such a this is very nice session taken by Dr. Fadnis. Thank you, sir.
Thank you, ma'am.
With this, we come to the end. But before that, I mean, we wind up with a few takeaways are here. So the physiotherapy being important in strength training, it is very, very important to follow POLIS in any acute joint bleed. So that is like you have to use the protection, go for optimal loading, ice, compression, and elevation. So this is the POLIS. Earlier we used to use price. Now it has become POLIS. The first takeaway for any joint bleed. First thing is that once you have a joint bleed, we'd always tell the patient, you go take a rest. Yes, you have to rest the joint with the bleed, but you don't have to rest the other body parts as well. You can continue to exercise on the contralateral limb once your pain limit is, once your pain is under control. So the very, very important part is that the moment your pain is down, the patient will start with isometric exercises, followed by other strength exercises involving the joints. So that is very, very important. So what we do is once we have a bleed, we have to encourage the patient to exercise once the bleed is down. So there is a protocol called as re-entry after bleed. Dr. Fadnas would like to elaborate on that.
Re-entry of the bleed. When the patient suffers from the hemarthrosis, suppose for example of a knee joint, then we, as Madam we perform the police that that the part is prevented from further damage or further bleeding, and it is stopped. Then after 24 hours, we can start with this isometric contraction of the muscles. For example, if I am taking the knee joint into this, so we contract the isometrically muscle quadriceps and further progress the strength of the quadriceps along with the co-contraction of the hamstring muscles. And then gradually, as the pain reduces and the muscle strength increases, we can give the load-bearing exercises along with that.
So we can make use of antagonistic muscle. That is, for example, if it is knee, we can make use of hamstring to relax the quadriceps and then engage the quadriceps after 24 hours. So this will maintain the balance of the joint, where both the component, that is agonist and antagonist, are engaged to maintain the health of the affected joint. Then we can progress to further level by increasing the hold, or by increasing the repetitions, or by increasing the difficulty level. So likewise, we can increase the strength of the affected joint, as well as we can increase the strength of the complete kinetic chain.
I think with this, we come to the end of the whole CME. I'd like to thank everybody who are present till the end, at the end of the Sunday. And I'd like to felicitate our chairperson with the Go Green memento from our society. I request Dr. Fatade sir to do the honors. Dr. Fadnis sir to please join. I request Fatade sir to please honor our speaker. Sir is our physiotherapist, and he's doing a voluntary clinic at the Lata Mangeshkar Birdy every Sunday for the hemophilic patient. Thank you so much.